what do I want to teach for you today? For you today, I would like to teach review of relevant anatomy. So I will actually show cadaver dissections where we can see how the nerves run out and move. And I'll take some of these cadavers and actually move them around so you can really see what happens when we're doing our various tests. Then we'll look at key neurologic assessments that you'll perform, and then we'll look at efficient ways to apply the neuro exams. And then I'm going to give you guys some case studies of different ones that I have. And if you want to look up any of these, you can do it on your own time too. If you just type in YouTube, luckily my last name is distinctive. Onto YouTube, you can just type in Vizniak Roger will be one of them. I herniated my own disc and had a whole bunch of neural symptoms and everything like that about 2 years ago. So I've gotten a nice one on low back pain. And then I'll go through a medical legal case where I had to be involved and give a subject matter expert opinion on the case itself. So to start, does the perfect neuro exam exist? Does it exist? Let me just run this out here. I'm seeing people shaking their heads a little bit. Mike Sider, does it exist? Perfect neuro exam? Don't know, right? I'm going to suggest to you that it does exist, and I'm going to pull up a video of the perfect neuro exam here. So just give me 2 seconds to get this up. Share screen right there. This is literally the perfect neuro exam. I'm going to tell you why it's so good. It's so good because it starts off with taking the patient history. Then you go through and do a neurologic assessment. So you're evaluating cerebellar function, balance, all this other stuff. And then she comes to the correct diagnosis at the end. It is absolutely amazing. Okay, everybody's looking at a screen with a pickup truck. Okay, all right, this is it. And you think I'm joking. I am, but I'm not. This is the best neuro exam that I have seen on the spot.
Oh, yeah. Well, I'm great. I'm doing okay.
I'm not so good because you were weaving all over the road there.
Well, so one thing straight.
Okay, so everybody heard that? That was the initial case history right there. I have not been drinking. She's concerned a little bit about how he's doing. I have not been drinking. All right. Right hand to the nose, cerebellar function.
I need you to recite the alphabet from Z to A backwards as fast as you can.
Mini mental status exam, alphabet backwards right here, right?
Yeah.
C Y X W V U T S R Q P O N M L K J I H G F E D C B A.
Remarkable. I've actually never seen anybody do that.
Okay, so everybody sees that. Could anybody even do that right now? He can do that, right? I love the officer. I've actually never seen anybody do that.
Oh, my bladder.
Ooh.
I'm not worried about your bladder right now.
Sure.
Tandem walk, nice.
All right, well, you got pretty good balance.
Thank you.
I want you to step up, step up, step up, step up, 5, 6, 7, 8. Step up, step up, step up. Array, kickball change, step left. 5, 6, 7, 8.
So good balance check, functional movement patterns right here. Excellent.
That was good. That's really good. You a dancer?
No, I'm just drunk.
Oh. Oh, so yeah, there we go. So that's a good one for us to look at right to start with right there. Okay. So what do you think of that exam? Pretty solid, right? Had a lot of fun with the patient right there doing it and actually came to the correct diagnosis at the end. Fantastic. Has anybody seen that video before? Yeah, it's absolutely hilarious. All right. The fact that he could go Z to A backwards correctly, that is absolutely amazing right there. But if I could encourage anything for all of us out there, whenever you're doing any exam or any interaction with patients, is have fun with it. Try and have fun with the interaction with the patient. Make it as light as possible for your optimal outcomes. So if we go back to the screen share right here, there is no such thing as the perfect neuro exam. Of course, it varies from person to person, but we have to keep some basic ideas under our belts to make sure we're following all of our bases. So the first slide I'll take you guys to now is going to be our basic clinical protocol. And when I'm doing like medical legal consultations and stuff, when I see people get things wrong, usually you fall apart a little bit when we fail to follow the basic medical protocols. Oh, this picture right here is pretty cool too for us to look at that shows, I don't know why students and doctors find this so much easier to look at for the layout of the dermatomes, the way that the person is bent over like that and showing just the different dermatome patterns. We'll get into true touch patches and everything later on, but just kind of a neat picture we just did last year. All right, what do I do now? Clickety click. Okay, so you should be looking at a slide that says the therapeutic interaction that we're going to start. When does your neuro exam start? Let me ask this to the class. Why don't you guys just tell me, when does the neuro exam start? Francis's dad, when does the neuro exam start? It's all right. I know I saw you mouth it. I heard you say it right. You said when you first look at the patient, that's when the neuro exam actually starts, right? We don't have to go into huge detail about the specifics of cranial nerves or anything like that just yet, but your neuro exam starts when you first observe the impression of their overall nervous system. How are they standing? Are they slouched over? All of this gives you a visual affect of how the person is likely going to be presenting for the entire visit. When we're going through, this is the process that you want to follow when you're looking at most of your interactions. It's hip nerves. And if you wanted to write a note down, be a good idea to do it. When I see students, because I teach a lot of students, or when I'm, again, doing these medical legal malpractice cases, it's usually a breakdown of this process that is lost for the doctor or the student who's not learning correctly. So first thing, greeting and observation, and then you're going to go and actually give informed consent. Okay, the O stands for observation, but you give informed consent to the assessment process. So usually what I like to do is start by checking how you're going to move around with some active range of motion, and maybe we'll do some quick neuro assessing, which involves me, palpating different areas, running hands over the skin, or checking motor function, whatever else it is. And then you go into your case history. So the H stands for history. And that's where you're going to be looking for outcome markers. What are things that you can evaluate over time to tell if this person is getting better or not? And help that patient celebrate the small victories. And I would even write that down as one of my key themes. One of my two key themes are going to be assessment is therapeutic. Okay, so I would even write that down. Assessment is therapeutic. A number of patients come in to see me. I get cases that are, when other healthcare providers are kind of lost a little bit, I tend to draw on those cases pretty much. And I treat a lot of therapists and doctors as well. So when they want to try and figure out better what's going on, that's what I tend to work with. So your assessment is very therapeutic for a lot of people, and you need to celebrate the small victories. Make a bigger deal out of all of a sudden, like I had a radial nerve lesion here on my hand, had full loss of sensation over the back of my hand right here. When you're starting to get little bits of that back, that's a productive, positive outcome. Support the patient through that process and say, yes, this is the kind of thing we're looking for. Or if it's something like an acute disc herniation that comes in, when they first come in, they're off to the side like this. And after you treat them for a little bit, then they're standing back upright. Those are small victories to celebrate, right? And you want to make sure that they're aware that we are part of facilitating that process. Establish yourself as an expert. That's one of my other big ones right there. Establish yourself as an expert. Okay. All right, so after you take your case history, you've got your outcome markers, then you've got the IPMNRS, so IP nerves. So then you go into inspection, and I say inspection instead of observation. If you know McGee's textbook from, I don't even know how old that one is now, but he goes observation as the second thing, right? If you're observing, that's you standing back. That's you looking from a distance at what's going on. I'm observing. So if I'm like watching my patient come in, that's an observation. But when we're in the clinic treatment room, now I am an inspector. I want to get my magnifying glass out and look very closely at what's going on with them. So now I go into inspection, palpation, motion assessment, neurovascular screens, and also into the referral options potentially as well. Because don't forget, the nervous system, as we know, has pretty significant referral patterns that we have to watch. We're not getting tricked on those, right? But these things can really happen in any order, depending on what you think is most important. All right. Really, the most important thing, and the literature supports this clearly, your differential diagnosis is made up from the history in about 75 to 90% of cases. You already know what's going on from the history that you take, but you're going to go ahead and finesse that and maybe rule out other potential causes with this inspection process. And then lowest on the rung, and this is what the literature is saying again, is actually your special tests. So those can be things like a brachial stretch test, cervical compression distraction, straight leg raises, all of that. But they're still confirmatory. There are good tests out there. Francis, your dad was asking, I don't think the human body has changed. Nope, you're absolutely right. The human body has not changed, but what has changed is our understanding of the validity and reliability of different tests that we perform. The other thing I want to point out to you as well is you can take your special tests and use them as outcome markers and use them as treatments. I'm going to stop the screen share for 1 second. All right. How many of you are using a straight leg raise test as a treatment for lumbar radiculopathy? Okay. Frank Martin is maybe, yeah, a little bit, right? Because we can learn all these nerve flossing techniques and everything else like this, but you can actually take a straight leg raise test and you can take the nerve to the point of initiation of symptoms and then come back off. Initiation of symptoms again and come back off. And every time you do that, think biomechanically, what are you doing? You're stretching the nerves out. You're increasing tolerance to that kind of pressure. You're moving fluid around into the low back or wherever else there's injuries, and you're loading along lines of stress. So I would encourage you to rethink how you actually do orthopedic tests. Standardly for cervical radiculopathies, I will use a brachial stretch test as part of the treatment, where I'll just say, okay, I got to make sure I'm in the camera here so we can all see this. I'll lean them back to the side like this, and I'll say, hey, lean in, lean out. A little bit of numbness and tingling is not the end of the world as long as it doesn't aggravate symptoms over the long term. So if you can take your special tests and turn them into treatments, again, your assessment is now therapeutic. Okay. And you can use outcome markers on that too. So let's say you do a straight leg raise and you get them up to 70 to 80 degrees, and all of a sudden we know how it really works, right? It's like a light switch. Numbness and tingling comes on, then it comes off. I'm actually going to challenge them into that barrier just a little bit to see how they tolerate it. And if by the end of the visit, they can give me an extra 10 degrees, there's a small victory we're going to celebrate right there. We're going to show that range of motion is already increased on our initial visit. You can do more than you think you can. All right. Is that gold right there, or is that gold? Give me a thumbs up if that's gold. Okay. I don't think that's standardly taught in schools. It's not one of the things that comes out on a regular basis. But I would encourage you guys. All right, Travis Wallace and Carolyn Lever, who I can't see, also gave the thumbs up. Fantastic. All right. Yeah. So all these orthopedic tests that we've learned, don't just throw them away because you can't use them or they're not relevant. Make them relevant for practice as outcome markers and treatments. Assessment is therapeutic. All right. I'll go back to the screen share. Do that down here on this one. And I'll go through, like, once we actually get into this, I'm going to go through by body region and kind of walk you through the specific things that we'll do by each body region in specific cases. And okay, so now you've gone through and done your special tests. You can use those as outcome markers. You have more detailed outcome markers. Now you're going to make your clinical impression or differential diagnosis, right? That's the bottom portion of this section right here, where you can see the special tests are going to be changing with that. Okay. Then you're going to go into treatment. And of course, before we begin treatment, there's a PAR-Q there. And we have to make sure we're covering this again, PAR-Q as part of our informed consent, right? Informed consent for treatment. So if you look at this, the way that I, knock on wood, take people and push them a little bit harder, but also avoid malpractice issues, is I am all about informed consent through multiple steps of the process. So most of us probably haven't seen it before, even at the start of the history. I'm saying, yeah, I'm going to be asking you some questions, then probably be moving you around. Do we have permission to go ahead and proceed with that? The other statement that I'll use all the time, especially I do this before treatment, is I'll ask the patient, who's the boss? I got to stop the screen share for a second. It's one of my favorite things to do, actually. I say, who's the boss here? Between you and me, who's the boss? Okay. If they're a confident patient, they'll give you one answer, but what do most people do? They're like, you are, sir? You're the boss? And I'm like, no, I am not the boss. You are the boss in this process. The patient is in charge. And as soon as you do that, what have I done? I've created a little bit of joke and humor in there, and I've let them know that they are in the position of power. They can stop and change things anytime that they want throughout the entire process. They're the boss. And that little bit of empowerment for patients is a huge outcome for them. All right, Dave, what do you think? Sounds reasonable? Yep. All right. This is why I like to see people's faces. I can see what you guys are doing, what people are saying. So yeah. All right. And I'll draw you in. Okay. Mike, if there's, is it oh, those are your glasses. I thought they were your sunglasses hanging down right there. Like it was a snowstorm and you're getting ready with your sunglasses to go out there in the nook of the north here. All right. Okay. So we'll continue on then. I'll go back to the screen share and finish off the last little bit of that. Okay. So what you can see is at the very end, the PAR Q is your informed consent. Just to review this to make sure we're all doing this correctly, P stands for procedures. What are you going to do and what is the rationale behind it? What are the benefits of this? Okay. A stands for alternatives. What are some alternatives to treatment that you can offer? And then the R is going to be the risks. What are the negative outcomes? And negative outcomes you want to include are going to be common and catastrophic. If it is a common thing, like a little bit of bruising or a little bit of soreness, mention it. If it is catastrophic potentially, and you think they might be at higher risk for it, then mention it as well. And then the last thing is everything has to be at a language level that the patient understands, and you give them an opportunity to ask any questions. So PAR Q stands for procedures, alternatives, risks, and if the patient has any questions. And then, of course, if you're reading the literature, you are failing your patients if you are not giving any kind of home care or follow-up exercises or anything like that for them. The research is pretty clear. The sooner you get people moving, the better off they are. But I'll come back to that in just a little bit of a second. All right. Then we'll progress a little bit more forward into this. Okay, the process that I've been going through lately, if you look at all the books, we just came out with this last year, all these seminars and everything, it's anatomy, assessment, action. All right. So what are you trying to do? Or I've got education here. Yeah, I've got education here is one of the things that we did. I've been giving out patients like full copies of books, and I realized that patients didn't really want that. So what we did is we wrote a whole bunch of little mini books, like one on low back pain, one on head and neck pain and everything that have a whole bunch of rehab exercises in them and pathology, educational processes that people can go through, even nutrition, sleeping habits, all of that basic stuff. So education, assessment, and then picking up your actions. And for the rest of this class, I'll pretty much just be teaching from the clinical chiropractic book just off of our website. So you guys will be able to see that. And you can do it, we can help. That's the big tagline I give everybody right now. You can do it, we can help. What are we doing? We are here as facilitators for the patient's optimal healing. In fact, the empowerment of the patient is going to result in the best outcomes you can get for them. And then we are there to help facilitate and make slight guidance and recommendations around their ultimate goals that they're trying to solve. And I guess I could do a quick quiz on you for something like this. I could say, name the nerve, name the structure, but I'm going to go back and get this all through the booklet when we do it here in a second. So exit out of this. Questions, comments so far. What are we thinking? Brett, what are you thinking? Got your ear pods in? AirPods are in there? No questions? Shannon, no questions? No, scanning through. Cheryl, give me 3 highlights you've already gotten from what I've said so far.
3 highlights from throughout. Challenge the small win. Challenge the celebrate small wins right off the bat immediately. Provide education.
Yep.
And give them an action step at the end.
Give them an action step, a call to action at the very end. Absolutely. Those are going to be fundamental steps right there, right? Okay. So I will go back to the screen share and take you guys through it. Doesn't everybody like that? I just got to make one comment on this. The thing that I like about Zoom is you can literally be in your bed, in your kitchen, whatever it is. It doesn't matter. It doesn't have to be so formal anymore for these educational processes, right? I feel like people get a lot more out of it when you can make it less formal like this. Even people are surprised when they hear me talk from the books and everything, because they kind of expect, well, we can see in the upper lateral portion of the meniscus here, we have a labral with there 3.5 mil. They'd expect that kind of stuff, but it works way better if you interact with just casual conversations. We're all a bunch of monkeys and that's how we learn. So, okay, let me get you guys through this. If anybody has any questions too, I'm seeing lots of good comments on the chat as well. Please feel free to even just take your microphone off mute and give me a shout out as well. Okay, so these are pages from the Clinical Chiropractic Handbook. I'm not going to go through the introduction or assessment foundations because we've kind of already done that a little bit right here, but where I am going to spend some time is on this section right there. So Everybody should right now, give me a thumbs up if you're looking at this. You should be looking at a case study on one side that says lupus and then the start of the neuro chapter on the other side. Yep, everybody's got that. Perfect. Okay, so this is page 903 of this book, and where we start off going through our basic learning objectives and discussing parts of a neurologic exam flow. Okay, one of the key things that I want everybody to get, though, is this discussion right down here. Most of you realize this, but this key point right down here, no one sign is of absolute significance in isolation. This is true for everything. No one sign, unless, of course, it's like a broken bone and you can see it sticking through the skin. No one sign in a neurologic exam is of absolute significance. All right. You have to correlate this with multiple other findings. And my basic recommendation is you need to have 3 different findings to suggest that you are correct before you actually make an official diagnosis with your neuro stuff. Neuro is a fairly highly accurate assessment tool to use if you know how to do it correctly. We're going to talk in a little bit about how to do reflexes and everything like that. The biggest errors are actually people not knowing how to do the procedures correctly. Okay. And also remembering your basic anatomy is one of the problems that people come into as well. All right. So what do we see? So I give a full exam of a neurologic exam that you might flow through right here. Let's be honest. If you guys want me to talk about this, I should be like, yeah, every patient, I do a full neuro exam. I do a full 1-hour neuro exam with every patient, right? Don't you all? Right? Let me, I got to stop the screen share so I can see everybody here. Okay. Right? Everybody does a full neuro assessment on every patient when they come in. Fully warranted, right? 1 hour, detailed cerebellar, reflexes, motor testing, cranial nerves, all of it. No, the research supports that this is actually not even warranted in practice in the vast majority of cases. Okay. You actually don't need to perform these. You need to perform a basic portion of it to actually get a good idea of what's going on, but we can definitely fast track these things. However, having said that, you should be aware of this skill set so that you do know if you have to pull out certain portions of it when it's relevant to do that. And also when you've reached your limit and I need to refer you and send you somewhere else, right? Okay. So I'll go back to my screen share. Chunk. Tell me that doesn't look slick, hey? When you flip through the pages here on this, doesn't that look neat? Right? Flipping through the pages. Flipping through the pages, pretty cool. All right. So key parts of a neurologic exam that you want to include. Well, the first thing is recognizing the red flags for more serious pathology. We all have this in our brains, but it's always a good idea to review this because, again, if you miss one of these signs, this can lead you down the wrong pathway potentially. I'm going to show you, I'll show you a cadaver dissection here in a little bit of the vertebral artery and how it runs up and through in the back of the neck and its relationship to neck motions. But headache, severe sudden onset of a headache is a major red flag, right? Worst headache of their life. A headache that includes visual changes that are causing them to, have blindness in one side or anything else like that. And that kind of correlates with this prior head injury. If they've had significant trauma, they've fallen and they're not wearing a helmet on a bike, or I don't know, a garage door fell on them or anything like this, or even a slip. You guys are out there in the snow and ice. Even a slip on the ice, you don't even realize it, but you crack your head on the back as you fall down. That's a major trauma right there, right? Dizziness, vertigo, nausea, and vomiting. These are red flags of more serious pathology, but they can also be intermingled with your migraine findings as well, right? So it's our job to figure out how severe is this. Seizures and tremors, definitely a major warning sign right there. Weakness and incoordination, more significant injury for sure. Numbness and tingling, we know that's more serious maybe, but it's variable highly on that one. Difficulty swallowing or speaking, yes. Stroke jumps to the top of your list. And then that significant past history could be there as well, especially if you have histories of brain cancers or anything like that. And nystagmus is variable, but it may be associated with vertebral basilar insufficiency or other issues of the brain stem. Well, in the brain itself. And then this loss of consciousness, you're all thinking concussions. And I'm going to go through in detail on some concussion options that you might have right there. Mental status exam, you want to do that. That's the video that we just saw, how to perform your good mental status exam. Cranial nerve exam. If you have forgotten how to do a cranial nerve exam, you can go onto YouTube and type in Vizniak cranial nerve exam, and I'll take you 10 minutes through a full cranial nerve exam on a patient right there that you can look at. Then we progress into cerebellar exam. So rapid alternating movements. Does anybody remember what this is called when you can't do the flipping correctly? It's got that wonderful name of dysdiadochokinesia, right? Just rolls off the tongue. Everybody remembers that one because we see it so often. You hardly will ever see it. Only seen it in stroke patients myself. So accessory movements, difficulty pointing or pass pointing with the head and pointing back and forth, ataxia, so uncoordinated gait, and the rebound phenomenon. I don't really recommend this one. It's in the literature a bit, but it's the one where you have them hold their arm out like this, you let go, and then they can't stop themselves from hitting themselves. Probably not the best test to actually use, but okay. Why are you hitting yourself? Be good to play with your little brother and sister, though. That's for sure. All right. And we can still do that as adults. Okay. Go out there and play with my kids all the time. I have 3 daughters, so they don't have a brother. So I'm the brother to my 3 daughters right there. So, all right. Francis, you don't look happy with that one. What's going on? Childhood trauma. I can see it right there.
No comments.
No comment. All right. We'll talk about it later. Okay. All right. And then you've got spinal cord and peripheral nerves that you want to check, posterior columns, lateral columns, basic motor function. This is our bread and butter right here. We can find a lot going on with these specifically. Deep tendon reflexes, and of course, pathologic reflexes. Most of you have seen this. I do some consultation for different colleges, colleges as well, chiro colleges, not Canadian Memorial, but actual registration colleges for licensure. And they're always like, yeah, we've seen this form 1,000 times. How many of you have seen this neurologic exam form right here? I know a number of chiros who actually use it. So yeah, it takes you through all of this process. I made up forms for every region of the body because realistically, this is my cheat sheet. This is my way to go through and say CC, significant history. And then I can go through mental status, reflexes, motor function really quick, and then cranial nerve, cerebellar, sensory, and nerve tension. And if you want this form, you can just go onto our website and they're free. These forms are available on our website for free, so you guys can access those. And even this quick review of dermatomes and peripheral nerve distribution as well, and the cranial nerve exam and all of that. So that's pretty useful for a lot of docs. All right, so you have an idea of the exam that you're actually going to be performing here. And then we go into the neuroanatomy, a quick review of some of the terminology that we should get. So I drew a homunculus out right here so we can see somatosensory and somatomotor. It's more detailed than I actually want to go into for this class. It's going to be a more basic class for us today. It's going to be a more functional class, really, is what I want to get over. But if you want to screenshot this, you can do it to remind yourself of where the tracks are, what their function is, and how we test those different tracks if you were doing detailed neurologic exams. This little table that I made up here is a table representation of this graph, right? So if you're looking at this is brainstem and then spinal cord below. You can see the decussation that's occurring right up here at the brainstem. Realistically, though, by the time we're getting into this level of detail, if I'm looking at contralateral signs, I am referring you to a neurologist. This is beyond where I'm typically going to spend my time, unless I really have a passion for it in practice. And for most of us, we're more orthopedic based, so I don't know that many of us are going to spend that much time. But if you wanted to, this is a resource where you can go ahead and look at the tracks and how they run. All right. Okay, joints in the nervous system. Yeah, there's Golgi tendon organs and muscle spindle fibers and all that good stuff. But what we're doing more of lately is talking about, because it's relevant for us directly in practice, is actually the neurologic receptors inside of joints. When we adjust a patient, we actually stimulate these neurologic receptors around the joints right here. How many of you have seen a graph like this before or a picture like this before? I'm going to go off the screen share for 1 second. Give me a thumbs up if you've seen that picture before. No, most people haven't. I'm surprised. This is something that most people haven't seen before. So I'm seeing no one. So we're going to spend some time with this one then. Good. This is perfect. Back to my screen share. Because we're always looking for mechanisms to explain the effectiveness of our care. If you go onto YouTube and you type in Vizniak, how many joints in the body? Oh my gosh. Oh yeah. This is kind of a neat one, actually. How many, forget the screen share. We're going to go back to this for a second, okay? Because we're talking about joints right here. How many joints are in the body? Just write some numbers in the comments there. How many joints, and I mean synovial, fibrous, sutural, what do you want to say? Amphiarthrosis, diarthroses. How many joints are in the human body? Most anatomy instructors can't answer this. I finally, I counted it out, and I had it checked by 3 PhD instructors at different universities, and I've given it to my classes to do repetitively. I got a video on it you can watch too, where it says how many joints. 865. Holy crap, that's big. Google says 360. I know Google says 360, right? Samantha, you got that one too? Google says 360, okay? So the number that we came out with was 472 joints plus or minus anatomical variation. So 472 joints. And do you know where most of the joints of the body are? Yep, that includes sutures. Yep. We didn't do infants. It's adult human skeleton. Adult human skeleton. I can see the comment questions coming up. Do you know where most of the joints of the body are? Come on, chiros. I know you guys know where most of the joints of the body are. The vast majority of the joints of the body are actually in your spine. Okay. There's over, I got to look at my numbers again. I'll pull up the sheet for you guys to look at it here in a second, but the most joints, the next most area for joints in the body is in the skull. All right. But most of the joints of your body are in the spine. If you take a thoracic vertebrae, typical thoracic vertebrae, I don't have one here. Do I? No, I don't have one with rib articulation. What am I doing? I got Skeleton Joe right beside me here. Okay. All right. You guys will like this. So look at this skeleton. We've actually taken some time and put the muscles where they attach over top as elastic bands that flex and stretch. So you can show this to a patient and say, look, this is how psoas works. This is how iliacus works. This is how quadratus lumborum, erector spinae all work. But if you look at a typical thoracic vertebrae, there are 12 joints per typical thoracic vertebrae. All right. I'll list them out for you because it's a good anatomy review. Because how many of us, why I feel so lucky to teach and go into the cadaver lab every year is how many of us are out there reviewing our anatomy on a regular basis, right? Hands up. Not many. Okay. All right. So when we're going through this, the joints are superior facet joints, inferior facet joints, and then the heads of the ribs articulate with the vertebrae above and the vertebrae below. So each typical thoracic vertebrae has 2 ribs that articulate with it. And it also has a costotransverse joint as well. So that gets you 10 joints. And then you would add to it the intervertebral disc above and below. And that gets you 12 articulations per thoracic vertebrae. Very complicated area right here. It's a little bit less up at T1 and a little bit less down at T11 and T12 because they're not typical, but it shows you the number of joints that are there and the number of receptors that you could actually influence with your adjustments. If you look up that Vizniak joints, the old video I did, we came up with 456 or something like that. What I actually do in that video is I show MRIs and real-time ultrasounds of what actually happens during an adjustment to stimulate these nerve receptors. So that's one thing we can. Do you guys want to actually see that video of what it looks like on an ultrasound when you do an adjustment to stimulate the nerve receptors? Okay. It'll take me a second to find it. Give me 2 seconds and I'll pull it up right here. Yeah. This is what we'll even do. Yeah, give me a second. I'll just find it on YouTube really quick. So I'm doing on YouTube is I'm just typing in Vizniak joints. Okay, Vizniak joints. Oh, we got a new one, but we got an old one that's 2 minutes long. So I'll just skip ahead to that.
Delicious for spring.
And I'll get through the ads here really quick too. Bum, bum, bum. How many of you were surprised by that number of the number of joints in the body? It's not something that people typically talk about, right? And yeah, right. We don't know that. Like how many bones are in the body? That's a pretty typical common question out there. Toss those ones out. How many bones in the body? 206, right? Wasn't that what the Guinness Book of World Records says? 206? Actually, the number is about 214 because everybody forgets to count the sesamoid bones of the thumb and the sesamoid bones of the big toes. And we all know if you have a patient with sesamoiditis or a sesamoid fracture or anything like that, those are part of it too, right? I've actually written the Guinness Book of World Records a couple of times saying, hey, can we update your numbers? And I haven't heard back from them yet. So surprise. All right. So let's go ahead and I will screen share this video for you guys really quick. You don't need to hear me talking about it. I give the list. What happens in a cavitation is there. Okay, get back to my screen share. All right. Does everybody see a video of me with my hands up, ready to do some jiu-jitsu on you? Okay. All right. So if we do this, this is from the joint play and mobilizations book, but we can see the graph on the side is taking you through what actually happens in a cavitation. And then for the book itself, we actually have a picture of well, these are ultrasounds of what actually happens during that cavitation process. So if I go ahead and play this, I'm just talking here, you don't have to hear it. Yeah, so this is an ultrasound, no, sorry, this is an MRI right here of a cavitation. It's a metacarpal phalangeal joint is what you're looking at. And so what you can see in this corner right here is this is the proximal bone and this is the distal bone. And you're going to see a black bubble form right here as we start to do our tribonucleation or cavitation taking place. Okay, so that was it right there. That's the black bubble formation in the center of what happens on the MRI. But the one that's going to be pretty amazing for you is going to be more of this one right here. So this is a real-time ultrasound of, again, a metacarpal phalangeal joint. You can see the distal bone right here. So this is going to be the proximal phalange. This is the metacarpal right here coming up. And all of this is joint capsule in between. Can everybody see that clearly right there? Yeah, I just want to make sure we can all see that. So I'm going to push play on this. And did everybody see that? That was the actual cavitation right there. You can see the gas bubble formation out of there and how it causes that instant stretch of the ligamentous structure around the joint capsule itself. Okay. I think I blow it in a little bit closer. Yeah. Boom. You hear the popping sound right there. And in fact, I'll go back just a little bit so you can actually hear the cavitation that happens with it. Unmute. Maybe I can't do the sound with it. Regardless, you can see what happens when we do a cavitation. Instant stimulation of joint mechanoreceptors in that area. Now, the follow-up for this is, what the heck are these mechanoreceptors that we're actually stimulating, right? So I can go out of this. Everybody's now looking back at that joint picture right there. Give me a thumbs up if you're back at the joint image with me. Yep, perfect. Okay. All right, so here we have the different types of receptors that exist. Let me zoom in as much as I can, that exist. So there are 4 types of receptors that you have inside of joints that we stimulate. People kind of think of ligaments and joint capsules as kind of this almost like a cartilaginous structure, not in the sense of its flexibility, but in the sense of its innervation. They are deeply and richly innervated for proprioceptive sense. So in the superficial capsule, you have these postural receptors right here. In the deep capsule, you have dynamic motion receptors that adapt fast when you're trying to cut and move. In the ligaments themselves, you have inhibitory receptors that actually prevent further damage from happening. And the one that you have in all areas are these pain receptors all the way through. Ligaments are highly innervated. Sorry, well, joint capsules are highly innervated, I should say right there. And this is just a drawing of the knee where we tried to show these are overlapping structures all the way through the joints itself. So when you go ahead and give someone adjustment, hopefully you're not fully stimulating the pain receptors, but you might be going to that area just a little bit, but you're looking at stimulating all of these receptors and potentially changing function around that joint. So as part of your neuro exam, even going through range of motion is a fundamental part of it. Never mind loosening up the muscles and grooving and functional movement patterns or anything like this. You're actually starting to see what their stability is inside of the joints. Maybe they had a previous ligamentous tear or something around the joint, and now the nerves don't work as well, don't fire as well. Maybe they have an area of increased sensitivity because of that prior damage as well. And our job is to change the sensitization of that tissue. So that's pretty cool stuff right there. Okay, the nerve receptors around a joint. I think it's fundamental for most chiropractic education programs that we get that out there and make it aware for, well, just basically our members, right? Okay, so that's that one right there. Then we can go into the neuro. And it's time for everybody's favorite game. You guys have been letting me talk for a while. So what do I need everybody to do? I need everybody to stand up and we're going to do the neuro dance. Okay. That's right, Mike. You're standing up, man. I can see you. You can't hide now. All right. We're all going to stand up and we're going to do our neuro dance really quick. All right. Everybody's doing this. Shannon, I can't tell. Kara, I can't tell if you're doing it. Carolyn, I'm just going to have to go on faith that you guys are doing it. Cheryl's doing it. Fantastic. All right. So how do we start? What I'm actually going to show you before we start is I want to show you something called true touch patches. Let me go back to the other screen share here. True touch patches. So what do you see? If you look at the anterior view, there are these things called true touch patches that in 99% or 95% of the population, that is accurately going to be that dermatome for the person. If you look at the research on dermatomes, they're not set in stone. They overlap a little bit and vary from person to person. But with a 99% confidence interval, these are my true touch patches with the blue dots here of the different regions. Okay. All right. So here we go. Here's our dermatome dance. Everybody's ready? Getting loose, and we're going to go V1, 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 V2, V2. Say it out loud with me. I need you guys to dance with me. Mike, you're doing it. V2, V2. You're going to come up just higher on the jaw, but down below the angle of the mouth, and you're going to go V3, V3, V3. And then you're going to go C1. Where the heck is C1? Oh, so I'm glad I'm testing you guys on this. Good. Okay. So understand this. There actually usually is not a C1 dermatome. The C1 does generally not have a dorsal root ganglion in about 75% of the population. So you typically don't see a C1 dermatome. What do we get? We go C2 on the top of our head. So up here, we're saying C2. Okay. And then we're going to go, well, even C2 can come under the back of the head a little bit here. And then C3 around the neck. Okay, saying it out loud, C3. And then we go C4 on the top of the shoulders, C4 on the top of the shoulders, C5 on the outside of the shoulder right here. Okay, C5 on the outside of the shoulder. Then we go C6. You can tap in a couple of different places, but C6 is going to be around right here, but anywhere down the forearm here is pretty good for C6. Everybody show me their C7s. Okay, there's your C7s. Francis, you can't do it? No, not appropriate? Okay. All right. So C7 is going to be the middle fingers running up and down right here. And then C8 is going to be on the ulnar side right here. And then you're going to come up into T1, and T1 varies a little bit, but anywhere into here is T1. Okay. And then we go down the body and you go T2, T3, hit your nipples for T4, right? And then the rest, T5, T6. These ones aren't really relevant unless you're looking at something like shingles. T10 is going to be your belly button. Okay. T10 is going to be the belly button. Then we'll scroll down here. And then what are we going to cycle into? I got to move this up. You're going to cycle into your lower extremity deep tendon reflexes. I think I can stand off to the side and you can actually see it behind me. That's probably too low for you guys. All right. So then what do we do? Into the upper part of your hips and into your groin. This is L1 right here. Okay. L1 into the groin. Then you're going to go L2 over the anterior thigh and the upper anterior thigh. I don't think I have enough angle to get down here. All right. Next one is going to be L3. And L3 is kind of over top of the knees right here is L3. Now, another one, because we're getting into the areas now we're going to see commonly with our lumbar disc issues, is going to be L4. Everybody palpate their L4 dermatome. This is one that we should all know because we do it regularly in practice. Okay. Yep. I'm glad we're doing this for the class because I can see some variation out there on how it is. So L4, I'll bring you guys back up. Maybe not quite that high. L4 is actually on the inside of your shin. This is where L4 is. And we know that, and I'm going to the branches of this later on. We know this is L4 because it's the terminal branch of the femoral nerve, the saphenous nerve that supplies this area. So please remember, just tap this and say L4, L4 right there. Okay. And you're not going to forget when you're doing your neuro checks. It's another major finding that'll help you figure out better than an MRI where the actual pathology is. Your physical exam skills make us better than MRIs, okay? A number of times I've had patients come in where it's literally because I can go through the exam well enough, I could tell them before they had the MRI where the problem was going to be found, okay? And if you want a way to build your practice, that's a way to build your practice right there, especially if you can send that letter to the medical doctors where you're ordering the MRI from, right? You can say findings are X, Y, and Z. Okay. L5 is going to be over top of the dorsum of the foot and the big toe, okay? L5 is dorsum of the foot and the big toe. And then S1 and S2 are interesting. S1 is on the outside of your foot, and it gives you that stripe down the back of your leg. So S1 is a stripe down the back of the leg on the lateral side, and then S2 is a stripe down the back of the leg on the medial side, okay? And then you're going to progress back up. And we all remember this because it's our running joke for school. Then what do? S3, S4, S5 as you get into the target of the anus there in that region. Generally, we don't need to check those ones, though, right? So yeah, the big ones to get, especially for us, are going to be the upper extremity and lower extremity dermatomes, especially L4, L5, S1. Most common locations for radiculopathies. And then you'll go up to the cervical spine. Same thing, and you're looking at your C5, 6, 7, 8, kind of cycling through those, and we want to make sure we can isolate those specifically. All right, was that fun? See what he did there? I made you guys get interactive with your learning opportunities right here, right? Rather than just sitting and droning on and on and on, you got to get up, you got to move, okay? You got to get up, you got to move. All right, the true touch patches. So on this image right here, you can see the blue dots indicate this is with 99% confidence going to be V1, V2, V3. When you start getting in these weird areas in between dermatomes, then your accuracy of assessment goes off a little bit, right? But what we did on this map is I drew it out so you could see the upper extremity dermatomes, but we can see on the other side the peripheral nerve layout as well. And this is the tricky thing that we have to get clinically. One of the first questions I'll ask myself is this a radicular problem or is this a peripheral nerve problem? Okay. And in a lot of cases, they can overlap substantially. And the prime example I'll give for that is going to be something like you've got somebody who's come in and they've been diagnosed with carpal tunnel syndrome. And we'll look at this in detail later on, but carpal tunnel syndrome, pretty common. We see that fairly regularly. So what should they have if they have carpal tunnel syndrome? Well, that's compression of the median nerve. That means I should see numbness and tingling over this region of the hand, over the fingers and thumb on this side. If they come in and they only have numbness and tingling on one side, like in one dermatome, and it's not over onto the middle finger, or even better yet, not even under the ring finger, the likelihood of it really being carpal tunnel syndrome is quite a bit lower. Okay. And of course, you would follow this up with your Phelan's test, which has pretty good reliability, or I would even modify it because it's a neurocompressive test. I would even modify it. I would do a Phelan's test, and then I would grab your median nerve and squeeze it even more, just like this, and see if I could see the symptoms actually be amplified with that. Yeah. Maybe I should just make one statement on this too. We understand how orthopedic tests work around this, right? There's two ways a test is going to give you a positive result for neurocompressive issues or nerve issues in general. It's going to give it to you from compression of the nerve, but it will also give you positive findings if you stretch the nerve out as well. So that's how Phelan's test works, right? Phelan's theoretically is supposed to compress the nerves, but we could reverse it and go into a reverse Phelan's and stretch the nerve out and look for that reproduction of numbness and tingling as well. So that's what a brachial stretch test is. When you lean back like this and you lean your head away, that leaning away is stretching out that nerve, okay? Or cervical compression test and you get long track symptoms. So not long track symptoms, you get dermatomal symptoms, distribution there, then that's going to also result in reproduction of the unilateral dermatomal loss of function. Okay. So that's the basics right there. So you want to be able to tell, is this a peripheral nerve or is this a dermatomal problem? I think for a lot of us, this is foundational where we actually excel compared to any other healthcare providers. This was key in most of our educational processes in school, and we are the experts on this topic right here. So how can you tell if it is radiculopathy? I'm just going to take a general statement right here. So if somebody has a radiculopathy, how can you tell? What are the key things you're looking for? It is, well, radiculopathy means nerve root. It is unilateral, okay, unilateral, and it is in a dermatomal or myotomal distribution. Dermatomal or myotomal distribution. And then you can pick your key tests. If it's in the cervical spine, one of the best tests you can do is a cervical compression test. But you can modify that test, right? Because we all know we get these kind of soft positives sometimes that I'm talking about before, right? Remember the statement I made, no finding in isolation is absolute. So if you have some numbness and tingling right here, okay, that's good. We can start with that. That gives us somewhere to begin with, but what else can I do? I can also check the myotomes for how the muscle contraction is. I could also do a cervical compression test. Let's say we do it and it's not really that positive. It doesn't really result in symptoms. So you can go ahead and modify that into your maximal cervical compression test, right? Where you progress through from just straight compression, you can go ahead and lean to the side a little bit, compress down. You can lean up and back in a little bit and even press down more to really challenge and close down that IVF and look for reproduction of symptoms. And you guys all get this, right? What's it like when you find it? It's one of my favorite things to diagnose. It's like a light switch. Literally, it's like symptoms on, symptoms off, symptoms on, symptoms off. If you can do that, you have isolated the specific location of the pathology. And then you do your little write-up that's going to say in 2 sentences or less, and you're going to send it to the neurologist, and they're going to be like, oh my gosh, this chiro is amazing. I'm going to start referring patients to them. Maybe they don't cause strokes with their adjustments. Okay. All right. Everybody gets the joke there, but it's a way that I've built my practice is basically just simple, good chart notes and letters to other professionals. So what I actually do is I give them copies of the books and say, hey, here's what I do kind of thing. And then they kind of take you a little more seriously that way too, if you're having issues. Okay. Gold. Okay. You guys have let me talk for a little while. So one of the key things that I know for human learning is we have to take regular breaks. So what I'd like to do right now is take a quick little 10-minute break. Everybody can get up and walk around. If you want another class that you can look at, because people are always like, how old are you? How have you written this many books, and practice and teach and everything like that? I have a thing on productivity that I put up on the web as well. So you can watch that on how to be more productive with your time. If you take this break and just pick up your cell phone and look at it, it will not be productive for you. You're going to come back more fatigued and more tired. The best thing you can do is get up and go for a walk around. Okay, go play with your kids, whatever else it's going to be. And maybe I'll see you guys in 10 minutes. Is that all? And then we can flip into there. Then we can talk a little bit about myotomes and sclerotomes. But the way that I like to do that is I like to do it with this fancy dancy little chart right here. How many of us have seen something like this before? I hope. Okay, everybody has seen these tables before where you can go ahead and look at it. Oh, Mike's taking it serious. The glasses are coming on. Fantastic. Okay, so you can tell by spinal level which area is involved. All right, so if I'm looking at a C5 spinal nerve root issue, I should see a loss in the deltoid function. I should see weakness in biceps as well. I should see a loss of the biceps reflex and numbness and tingling over top of the C5 dermatome. If you see those three things, you are almost guaranteed to be 100% accurate on looking for a C5 nerve root issue. Now, I can remember as a student, I actually gave myself a residency at the Portland Providence ER. So I went into the ER for 6 months, got to know all the medical staff there, emergency area there, and they took me under their wing. The doctors treated me like a resident and everything. It was fantastic. And one of the patients that we saw there was a guy who fell out of a tree as a kid and twisted his neck. And he said, yep, for the rest of my life, I've actually had no deltoid muscle on this side. And you could see his deltoid was all scooped out on this side. And you could see that he had no sensation over top of this area. And it's been that way since he was a kid. So long-term atrophy that occurred. Obviously, when he fell out of the tree, the apex of force came in and severed his crush injury, however it happened, severed his C5 spinal nerve root so that he no longer had innervation to any of those tissues. And that's just the way that he was after that injury. So you can see it manifest in severe injuries like that. C6, what should you be looking for? Oh, it's biceps again, but now we're going to go down the limb a little bit further into the extension of the wrist is going to be weak. So C6, a little bit of weakness in the wrist, and the big reflex here, that brachioradialis reflex. All right. And then the dermatome is going to be over top of the arm and thumb is what you're looking at. C7 is going to be triceps. And it's going to be looking at weakness in wrist flexion now coming down the other side, or finger extension and loss of triceps reflex. And C7 is that middle finger. If you want to show it, if it's too much, you don't have to show it. Francis, that was for you. All right. Okay. And then if we move on, T1, no reflex for it, but this is going to be your quick check of spreading of the fingers and closing of the fingers back and forth, right? Get your jazz hands out. Yes, I can. Okay. Jazz hands are going to work for you there. Progressing into the lower body, this is bread and butter right here. If you're watching this and you're on a computer, screenshot it. You should just know this off by heart right here. This is a basic one for us to make sure that we all understand. So L4 spinal nerve root, you're going to be looking at a weakness in quadricep contraction. Does anybody know what peripheral nerve supplies the quadriceps? Mentioned it earlier. Do these little quizzes all the time. Peripheral nerve is I can see you saying it, Francis, the femoral nerve. Okay. It is the femoral nerve. And I'm going to actually break down the nerves for you in a little bit. So it's the femoral nerve that supplies it. You can also have weakness with tibialis anterior as that lateral branch comes down. You can also see patellar DTR is lost. And again, I have to stress this. This is how I know right away I'm looking at an L4 issue. The dermatome is on the medial side of the leg. Okay. Medial side of the leg. Please get that. Loss of patellar reflex, medial side of the leg, lack of sensation, and maybe some quad weakness. Yep, I'm looking at an L4 spinal nerve root issue. An orthopedic test you could toss out there is not going to be a cervical compression test, but one that I will use with people on occasion is I'll put my hands on their shoulders and I will push down on their shoulders to load their lumbar spine. I'll even do it with them leaning to the side and then load their lumbar spine a little bit more and look for reproduction of symptoms. So a lumbar compression test. How many of you have heard of a lumbar compression test before? Nope, not typically taught in school. So if you want, add it to your list of these are Dr. Nick's highlights. Okay. If you're smart, you're being like Shannon right now. Shannon, you are smart. I can tell because you are writing this stuff down. Okay. The only way you're going to remember it is if you actually write it down and make it part of your practice. So smart people are writing it right now. So a lumbar compression test or a lumbar maximal compression test you could look at. Now, I bring this stuff up as though there's research on it. A lot of these things don't have research. These are just variations that I've come up with over the years that make anatomical sense. Does it biomechanically work? Then yes, I think it's something I can apply. I cannot tell you the sensitivity and specificity for this patient population is going to result in positive predictive values for da-da-da-da. I can't tell you that. But I can tell you it's something quick and easy to do, and it makes anatomical sense. So why not give it a try? Okay. All right. Next thing is going to be the L5 spinal level. And so for L5, what do we get there? That is dorsiflexion. That can be the person walking on their heels, so their toes are up in the air or lifting their big toe. And this is a tricky one that a lot of people get. Is that hamstring reflex. How many of you are checking a hamstring reflex? This is a tricky one to actually do. So what you do is you actually grab the inside of the thigh and you pull up on the semitendinosus tendon and you actually strike your own finger like you do on a biceps. And you look for that tendon to push into your finger a little bit. Okay. On this one case, I'm going to show you here in a little bit. That's an example of it right there where I show it on this guy named Roger, where we identified a specific radiculopathy that he had. Okay, next one is going to be S1, and S1 is plantar flexion. Get the person to walk on their toes. Are they able to do that? Can they invert and evert with the peronei muscles? And the reflex there, super obvious, super easy to get, is going to be the Achilles reflex. But the key thing to get for an Achilles reflex is it is absent quite often in geriatric patient populations. It is common for old people to lose this reflex. Okay, so just because it's not there doesn't mean anything. But geriatric patient populations, we know what's happened. In fact, it's happening to all of us a little bit right now. What are we all doing?
Sitting.
We're aging. Yeah. We're all dying a little bit every day. Okay, so you're losing some of your nerves, some of your sensation, your sense of taste, smell, vision. All neurologic function decreases generally with age. We can help maintain it by the lifestyle choices that we make and the treatments that we get. But at the end of the day, it's normal for the Achilles reflex to be absent in geriatric patient populations. So please be aware of that. All right. Yeah, so that's just a nice summary page right there. If you screenshotted it, great. You got some good information there. Okay.
There was a question about the use of Valsalva.
Yep.
Do you
yeah.
still use it?
Yeah. So Valsalva is a great test, but Valsalva only comes up positive if you have a herniation, right? So what I'm doing is I'm using the term radiculopathy loosely because there could be multiple different things that cause radiculopathies. As chiros, what do we typically do? We put on our blinders of bias a little bit, and what do we see? We see disc joint, disc joint, disc. Okay. But there can be other causes of radiculopathy. In this case of Roger that I'll show you guys here in a bit is an example of that. He did actually have a small disc herniation. I do not remember specifically if Valsalva was positive or not, but he also had osteophyte stenosis as well, lateral recess syndrome basically, that was occurring at the same time. So it amplified his symptoms. You can have radiculopathy symptoms without disc herniation. Okay. However, if you do see it worse with coughing, sneezing, or straining, Valsalva maneuvers or Desjardins triad, it highly increases the risk or likelihood of the person actually having a disc herniation. But let's go even better onto the Valsalva. Okay. Valsalva is a good one, but it's good for any type of herniation. If you have a lumbar disc, a cervical disc, if you have a femoral or inguinal hernia, Valsalva is positive. If you have an umbilical hernia, it's positive. If you have a hiatal hernia where the stomach is coming up above the diaphragm, it can aggravate symptoms. So Valsalva is a good test. Okay. But again, like we said before, I would never use it as a single test to say this is what's going on. It's part of the clinical picture to improve the relevance of the specific pathology that you think might be there, to rule it in or rule it out, basically, right? But really good question. Can't usually get a response on the hamstring reflex. You're absolutely right. It's difficult to get unless the person has really, really brisk reflexes. You're often not going to see it. It's not the end of the world if you don't get the hamstring reflex, but if you did get it on one side and you didn't get it on the other side, and they had other symptoms that showed numbness and tingling in the L5 dermatome and weakness with dorsiflexion, then it becomes more relevant. It's just one little piece of the clinical picture. And because it only takes literally all of, what's it going to take you? Maybe 10 seconds to do. Yeah, just go ahead and try it out, right? I will make a comment on this, and I make a comment on in the Roger video as well. How many of you use reflex hammers like this? Okay. Yeah, this is a standard reflex hammer that most of us see. Now, I do a lot of home renovations, and I like to do a lot of outdoor kind of work and stuff like that. I do a lot of welding and everything too. So I'm always chipping slag on welds for things that I'm making. Follow me on Instagram. You would have seen my aluminum trailer that I made this year with the COVID lockdown. Okay. But anyways, this hammer is pretty light. Okay. You can get reflexes with this, but if you look at the way I'm striking, I'm giving that good hit. You can see the hand actually vibrates, but it's pretty light. What do I recommend? Especially for students, I recommend a hammer more like this. Everybody see the difference in that hammer shape? It's called a Tromner reflex hammer. And what is it? The hammer itself is all stainless and everything like this, but it's heavy. So what happens is it literally drops and gets the reflexes for you that way. And it might not seem like a big deal, but the equipment you use makes a big difference, right? So if I'm trying to get reflexes, a hammer like this allows me to get more stress, more pressure into it, more accurate assessment, I think. So I would just toss it out there for an idea. I know it's probably been a while since we all bought new reflex hammers, but just something that I would suggest to you. A slightly more specific or heavier reflex hammer might give you a bit more out of it. Queen's hammer for lower. Not sure about Queen's hammer. In my doctor's bag, I actually have, what do I have? 7 or 8 different reflex hammers. I got all the Babinski hammers, all kinds of different ones and everything like this. If you look at most neurologists, they'll usually recommend a hammer like this just because they're more accurate with it, they feel like. So, okay. Let's go ahead back to our screen share though, or even before I go on, any other questions? Brett, I'm loving this, man. You're taking good notes. You are fully engaged, sir. Fantastic. Okay. Yep. Don't write on your screen. Okay. You wreck your camera. All right. All right. So this next section right here, again, I'm not going to go into detail on this. If you wanted to look at it, this is where in the book I break down the specifics of different lesion patterns. The one that might trick you, because we are seeing increasing cases, especially in the US, we're seeing increasing cases, is this peripheral neuropathy case right here. So I'll zoom in onto this. This is where I break down different pathologies by their presentation of numbness and tingling. So if somebody has a peripheral neuropathy, most likely the increasing case is going to be a diabetic neuropathy is what you're looking at, or they could potentially have some kind of nutritional deficiency or pernicious anemia here. But regardless, you're looking at bilateral symptoms. As soon as you see bilateral symptoms, you're either thinking central nervous system problem, most likely in the spinal cord, or you are thinking peripheral neuropathy secondary to some kind of metabolic condition, okay? And the big one for us to get for diabetes is the stocking glove anesthesia. So what happens is they start to get numbness and tingling or altered perception, and it starts with the longest nerves of the body first. So this is where the stocking anesthesia comes in. They feel the numbness, tingling, coldness in their feet, that starts. And then as they reach nerves that are the same length in their feet and in their hands, see how I'm doing this? I'm wearing my fancy shoes today. In their feet and their hands, okay? In their feet. Talking to my kids here, in their feet. All right, so you're moving up like this and you're bringing it up. Then you start to see the stocking glove anesthesia occurring into the fingertips as it progresses up around the ankles. So that's what you want to get. If you see bilateral symptoms, be thinking metabolic condition. And if it's a metabolic condition, this is something where you need to refer this person out, right? Further evaluation is required on this. And I mean, there's the good potential here. If you catch this early, you can make a big difference for them because with a lot of these conditions, they are reversible. If it's pernicious anemia, you can be looking at appropriate supplementation to prevent that from happening. If it's diabetes and well, it's going to be a mid to late stage finding, but still you can offer benefit with these people. Okay. All right. Syringomyelia, super rare, probably never going to see it. But if you did, this is going to be that shawl-like distribution over both limbs, okay, and the upper body. Individual nerve roots, that's where I'm going to spend my time mostly today when we get into it, because this is what we tend to see mostly in practice, people coming in with these. The rest of these are going to be these spinal cord lesions. You're looking at bilateral symptoms or contralateral symptoms on the head and face for stroke type presentations. That is not in my office. I need you to go somewhere else right away. If it is these individual nerve roots, yep, that's something you can handle in office, not a big deal at all. Cauda equina syndrome. Dun, dun, dun. Yes, this is one that you have to make sure you recognize right away. Exam question, because everybody knows there's going to be exam here, right? Francis told you at the end there's a 50-question exam that we're going to be doing. Okay, look at the awkward smile. What? Yeah, I will do a quick quiz for you guys on the end, and I'm just looking for you to verbalize some of the things you're going to take away from today's lesson. But for cauda equina, what is it? It's a large central disc herniation, all right? It can also be secondary to tumors that will result in the same symptoms, but usually disc herniation is the most common one that we're going to see. Loss of bowel and bladder control and bilateral saddle anesthesia is what you're looking at. If they have this, those are major red flags for you. I'm going to go into detail on it on a little bit, but just make sure we can recognize the basics of cauda equina syndrome. As a student, the very second patient that I saw had cauda equina syndrome that walked into the student health center there. Okay, so I will never forget it. And we did x-rays, and guess what the x-rays showed? Nothing. The x-rays showed slight decrease in joint height, but that was basically it. So you don't diagnose it that way. So she had all the symptoms for it. Progressing through, this is just breakdown of the axillary and radial nerves, but I'm going to give you way better pictures than this for us to look at. This is going to be a breakdown of what happens for CNS lesions of the brain. Key thing to get here is you are looking at head and face and body lesions. Those tell you that you're probably looking at a brain problem right there, brain or brainstem issue. Okay. I'm not going to say too much about it. Don't have to worry about these. Cerebellar occlusions, not a big deal. Okay. At the end of the day, when you see symptoms that are weird like this, they are not in your office anymore. You're sending them out. So we don't have to spend a bunch of time.
There are a couple follow-up questions regarding cauda equina.
Okay.
More detail. So is it just a loss of control? Is it increased frequency, extreme constipation? Does it vary? There's also question around cauda equina as a chronic or a recurrent condition. So
okay.
Yeah.
Let's skip ahead to do that then right now. So I'll jump ahead into cauda equina because it's a relevant topic for us to get. So let me jump ahead to that. So I got to get out of this for a second. Cauda equina is going to be, oh, now I got to find where I put it in the book though. Did I put it in systemics or did I put it in lumbar? Probably put it in lumbar. Okay. So let me go ahead back to my screen share right here. It can fall in two different areas depending on how you want to apply it, but cauda equina. Or you know what I can do? There's this wonderful thing in books called, like, check this out. I didn't even realize we had this. I can go ahead and look at this little thing called the index at the very start, right? Okay, so if I'm looking here, cauda equina, C-A-U equina, page 680. Oh yeah, it'll be in here for you guys. 680. Yeah, there we go, page 680. So I'm just going to cycle ahead really quick. All this stuff. What am I at? Oh, a little bit too far. 682, leg length inequalities. Okay, so let's go ahead and talk in detail about cauda equina syndrome right here. So a couple of key things for us to get. We'll zoom right in. Number one, let's just recognize anatomically what the cauda equina is. Cauda equina is here at the very bottom. So your spinal cord roughly ends at approximately L2-ish, L1, L2, somewhere in there. And then we have that horse's tail that comes down the rest of the way. That's where our name comes from. And we see a distribution kind of in this saddle anesthesia area. So the specific questions are, it can be variably expressed, but the big thing is 95% specific, 90% sensitive with recent difficulty with urination and defecation. All right. So that can be whether it's retention or the example that I saw early on in my career, she was a farmer and she went and she was about the same height as me, 65 years old. She lifted the side of a 65-gallon drum, pushed up, twisted, and then immediately dropped to her knees and urinated. Those were her symptoms right there. So she had instant onset of muscle weakness, loss of bladder control right off the bat, Those were the main findings that she had, but it can be variable because we know that these neurologic symptoms are not consistent from one person to the next. It can be variable from one person to the next. Okay. The big finding is that saddle anesthesia though. And some people might describe it as weird sensations like altered sensation when they're urinating or altered sensation during intercourse as well as another one that you might see. And yeah, it can be, one of the questions was, can it be a chronic condition? Yes, especially if they have, so I'm giving you an example like this, where it's a large central disc herniation pushing out on that cauda equina, or it can be even this example here. It is still a disc herniation pushing out, but what if I actually have stenosis that's causing that, right? That stenosis will lead to long-standing cauda equina-like symptoms, and that patient might actually need surgical decompression in those cases, right? The real risk here is long-term neurologic compromise from the compression of the nerves. And if you can avoid having a colostomy bag or anything else like this because you have loss of bowel and bladder control, the standard recommendation here is referral for emergency consultation. If you see this, I'm going to stop the screen share for a second just so I can see more of the questions. If you see this, don't take the risk on yourself. It's not worth doing. Okay. You're way better off to refer for co-management with a medical doctor or somebody else who can also share the risk. You can say, these are the symptoms. I expect what's going on here. I want to rule this out. The case that I saw initially, the person had all of these symptoms, and she saw a chiro in Vancouver, Washington, which was just across the river from Portland. And it was 2 weeks earlier. And all she was given was an adjustment, which would actually be contraindicated, just so we're clear. An adjustment is contraindicated in cauda equina. And in fact, adjustments can even take disc herniations and rupture them more if they're really a high force adjustment with a lot of twisting, flexion action into it. And she was given an adjustment and some home care exercises. So when she came in to see me, she was literally with a cane and her brother kind of walking in like this. And she was like, I just wanted to get a second opinion and see what's going on here. Well, then we go through the x-rays and everything like that. But she was at the stage where she was stable. So she was lucky. Things didn't advance. She was actually getting a little bit better. But my key point of treatment for her was education around the warning signs. If you lose bladder control again, if you feel leg weakness again, you need to go to the ER. That's where she needs to be, right? And it was very clear in my chart notes that was what was going on. But actually, she eventually had just natural resolution of the condition. Okay. But just to be clear, I wrote a letter for the other doc in Washington. I said, hey, these are major findings that you missed, because he didn't diagnose cauda equina syndrome. He just thought it was a low back strain or something, which maybe the wrong questions were asked or something. I don't know how you would miss it, because it's pretty obvious when you see it. But regardless, it's a point of education that you give. Like whenever you write a letter to another doc, or you just give them a call and say, hey, this is what happened, I would want to have it happen to me too. If I miss something, I want somebody to tell me what I missed and how I missed it. So it's an educational opportunity there, right? And so, that would be kind of be that case right there. Can cauda equina be chronic? Yeah, I don't know if I would call it chronic. I would call it more of if it's chronic, disc issues should resolve relatively quickly. The research is pretty clear on that. Even large herniations actually resolve faster than smaller herniations. Are we aware of that? Or most people have heard that research before? Larger herniations, yeah. Okay, so if you have a larger disc herniation, like we're looking at in cauda equina, your body mounts a larger inflammatory response. So you get more macrophages and neutrophils, everything rushes in there faster, and it actually starts to break it down a lot sooner. So there's research that supports those things actually healing faster with a larger herniation. It's these smaller ones that are associated with things like the stenosis, thickening of the ligamentum flavum and all of that, that actually take longer and can become more of these chronic conditions. And in that case, a chronic cauda equina, I would be looking at x-rays and MRIs looking for a stenosis type issue. Neurogenic claudication, right? Neurogenic claudication is what you're looking at here. All right. So clearly she had been bad that first visit with the other doc. Yeah, so that's the one comment that's up there. Yes, I can't, if you give me a history of literally, like I couldn't ask, I was lucky, I couldn't ask for a better history. If somebody comes in and tells you the primary disc injury mechanism of lifting a 65-gallon drum, standing it up, twisting, and then dropping to my knees and instantly urinating, yes, that is like ultra obvious symptoms right there. Like that is something you have to pick up. If you don't, that is you are on the verge of malpractice. Now that other doc is lucky because nothing negative happened out of it. I'm going to try, and if we have time, you guys are getting me chatting up because these are good questions. If we have time, I'm going to go through a case at the end of this of a naturopathic doctor who did an adjustment that was contraindicated, and actually I was involved as the legal consult in this case, who actually caused cauda equina syndrome from the adjustment that they did. And they failed to follow informed consent and recognize a bunch of key neurologic findings that should have been recognized that were all written in the chart notes, and still they did the adjustment. It was like one or two I could see you missing, but it was like 5 key things that were missed. So that's kind of where we're going with this. Yeah, so here's a question. A lot of patients say they have frequent urination with acute low back pain. Mechanism, muscle spasm compressing the bladder. This is a tough one to go ahead and make connections to. I've not read anything specific on it saying that this will cause increased urination. I mean, even for my own disc herniation that I had 2 years ago, there's a YouTube video on it you can go ahead and watch. And I walk through how the injury happened, what I actually did for movement, and what I did for treatment on it. I was back at the very start of it though. What actually happened is I'm moving these big steel beams, and then I go ahead and start tossing some rocks around, and I'm bent over in a flexed position. And my very first symptom was instant pain. Like I heard a snap in my back, instant pain, and pain down into my groin, right? Which is not typical for most disc herniations for that groin pain. But depending on how it compresses nerves, because we know that these nerves still run and supply the bladder from that area as well, and can compress the spinal nerve roots that actually run out for S2, 3, and 4, you can get variable symptoms with it. Now, I don't necessarily know that I could say muscle spasm compressing the bladder. That would be like, which muscle is compressing the bladder, right? If you're female, you have the extra uterus in there in the way, but if you look at the actual anatomy, the bladder is buried so deep into your pelvis, pelvic floor typically. No, I can't really see that occurring right there, right? Like direct compression that way. I can only see it as a secondary neurologic misinterpretation from some kind of referral pattern, right? Because maybe what you think is you've got an injury in there, and what it's doing is compressing the same nerves that supply the bladder, that supply the other regions of those same muscles as they go into the dorsal root branches and all of that stuff, right? So, but I can't give you a specific one on it. Okay, but that's just me speculating right there. Let's get back into the hardcore science, right? What are you here for, Mike? Hardcore science, okay? All right, so let's go ahead. Oh, is there a question? Yeah. The mechanism for low back pain and constipation would be the same thing. It's going to potentially be neurocompressive changes, or, well, okay, low back pain is a tricky thing. There's times when it's obvious and times when it's not obvious. Souza talks about this a little bit with, you can even have low back compartment syndromes, right? Like we think of a compartment syndrome, we right away jump to tibialis anterior as the location for a compartment syndrome. Or if you have rock climbers that you treat, I'll see a lot of forearms that have compartment syndromes there as well. But you can also have compartment syndromes isolated deep in the low back, potentially, that you can sometimes see on MRI with the swelling and increased diffusion in the tissue, but it's not super common. The mechanism for constipation, like I said before, the mechanism for gastroesophageal reflux and all that kind of stuff is poorly understood. There's some mechanisms that say it's going to be sympathetic, parasympathetic occurrence with that, the stimulation there. Some are going to say referral patterns because of compression. I cannot give you any concrete answers on this. If anybody has any research out there where they do have good answers for mechanisms, I would love to see it if you can send it to me. So, but that's kind of what I'll say right there. Also ask about medication use, NSAIDs and constipation. Kind of a tricky one. If I was to take you on the constipation pathway a little bit more, I think a more major player is actually lack of physical activity. Because what happens for people when their back gets sore? They stop exercising, they stop moving. Well, we know, I mean, I teach yoga classes. I'm a certified yoga instructor. There's research that supports mobility is good for constipation. Exercise is good for constipation, right? So if you stop moving, this might be another, again, I'm speculating here, but it could be what's involved for the people that you're treating. They've stopped exercising their low backs. If you guys want one of my biggest tips that I can give you in practice for anybody with low back pain is get them moving as soon as you can. It doesn't matter how bad it is, get them moving as soon as you can, and you're going to see better outcomes with it. Okay. On the NSAIDs, if you said narcotic analgesics or opioids, then yes, there's definite mechanism of action right there where you see decreased GI motility with the use of things. Well, heroin is the prime example, What do you see for a lot of heroin addicts in extreme cases is they have full-on constipation and they're not contracting their GI tract very much at all until they have explosive bouts of it at the very end, potentially. But for the NSAIDs, same thing. They might not just be moving as much, but I can't, again, draw a specific mechanism on COX-2 inhibitors or anything like that. So yeah. But again, you guys are making me speculate. Great questions. I have no firm answers on that. Exercise would be one of the first things that I would look at. And also for an engagement for your patients, getting them moving as soon as possible. Or even better yet, like, let's be serious. What do we really do? We actually give patients permission to move, right? Don't you find a lot of people who come in, they're scared to move, or they've been told by somebody else, oh, you shouldn't really be doing this exercise, or you need to rest it for 2 weeks or whatever else it's going to be, right? What we need to do, my biggest successful outcomes in practice are giving people permission to move early in a safe way and showing them how they can do that right there in your office, right? And in a lot of cases, what did I have on Thursday? This Croatian tennis player, elite level tennis player, he fell off of, he also works in a warehouse part-time as well. And he fell in a warehouse, and the case history was interesting because English is a second language, so we had to go through it. But the case history was this: oh yeah, I fell 6 feet off of a pallet onto the cement floor on my back, is what he said. And his back is like a rock. He hasn't been at work for 3 days. He can't even move it. Went in for a massage, couldn't even do anything, right? So what did we do? We go ahead and ask more questions around the history. And then I'm like, so that's how high you fell, just that high, but the cement was hard. Yeah. And you didn't fall anything before. Oh no. And then you pull it out of him. Oh yeah, I actually fell 12 feet off of the pallet racking onto the pallet. And then I fell onto the cement. And so you get a more detailed history with this, right? But the point I'm trying to make here is when he came in, his back felt ultra tight. As soon as I pushed on his back, he just jumped. He didn't want to move at all. But by the time the visit was done, all of 20 minutes later, I could almost bury my thumb into his erector spinae and he could move again. How do you get these outcomes? You get these outcomes by challenging people in these areas where they have these injuries and showing them where is the pain or where is it actually perceived pain. He thought it was going to be painful. And at the very start, his perception was, yeah, I can't do this. So you go and work around in other areas, do our standard side twists, see how he tolerates that, and then come back and push on that same area. And he was already able to handle way more movement, way more pressure. So that's how I'm going to make that transition for him, to show him on his own body that I can push harder. And now he can move a little bit earlier. And the same thing for that low back is you're going to get them moving sooner. All right. You guys got me off a little bit on that one though. Sorry. Okay. If you guys see me disappear into those two, it's like, say, bring me back. But the sooner you can get people to move. The research is clear on this, like abundantly clear. I think our best outcomes, yeah, we can say we stimulate nerves and do all this stuff in the joint mechanoreceptors and all that, which is great to modify pain and everything, increase range of motion, but it's getting people moving sooner. That's what we really do. What do we all actually? I want everybody to do this. Take your hands and curl them into little curls like this. All right. This is called cinnamon bun hands right here. Cinnamon bun hands. All right. Do it with both sides. Cinnamon bun hands. What do we really do? We put our hands up and say, yes, you can. Everybody say it with me. Yes, you can. Dude, Brett, there we go. Yes, you can. That's what you do with patients. We are all really coaches and cheerleaders to give them permission to move sooner. And I will actually use that with a patient as well. Because as you know, research out of Harvard, what is this? This is a power pose. This is a position that improves mental affect in most people. All right. Power poses, use them when you can. All right, get a little bit emotional around that one too. That's why my voice fluctuated. Okay, but back to cauda equina. I mean, what are you going to do if you're going to be looking at what you're going to do with that? Now that you've shared the risk and you have this person managed with somebody else, referral for emergency imaging is going to be there, especially if there's sudden onset of bowel or bladder symptoms. You're going to be looking at basic, simple movement activities that are going to challenge the area. Something as simple as pelvic tilts, moving back and forth are not going to be a bad idea. Most of these people are going to be more comfortable laying on their back because it's a decompressive load on the spine. So you could start with, let's make it as functional as we can. Even a simple dead bug track is going to work where you can lift your arms up, lift your legs up, and you're going to give that key finding for them that if the pain is sharp, if you feel increased in the saddle anesthesia in between your legs, then that means it was too much. Otherwise, the more you move, the better off you're going to be, because even that movement, takes the discs and flexes and extends their spines a little bit for this neutral pelvis. Well, that pumps fluid in and out of that area. That stimulates nerves. That enhances the healing process. The body knows how to lay down new collagen and load that area correctly. Patients with mild forms, there's something wrong with my formatting here, but patients with mild forms have excellent prognosis for full recovery. The more severe forms, the more severe symptoms, the worse the recovery rates might be. But the key thing you have to get is there is a poor correlation between what you see on the x-rays and MRIs and the actual patient presentation. You can have this full load compression and the person can have almost normal function, and you could have relatively minor compression and they could have severe symptoms. So do not get fixated on the imaging, okay? Which a lot of docs do. They won't even do anything on the person until I see an MRI or an x-ray. No, you need to find functional solutions for this person earlier on. And a big part of that is just challenging their ranges to begin with. Okay. All right. So that's the cauda equina right there. Biggest thing, don't take the risk on yourself, share it with other people. All right. An MRI, of course, is the gold standard. Make sure you're doing that. X-ray is really not going to show you anything unless you're trying to rule out another fracture or something like this. Okay. I'm going to go back to my screen share into this one. Cerebellar function tests. I'm not really going to spend too much time on that. Not a big deal. Yeah. Babinski, that's got some pretty good research behind it to actually have good validity for upper motor neuron lesions. But if somebody is Babinski positive, what are you thinking? You are thinking stroke or more significant injury like that, right? You are not looking for your peripheral neurologies. Okay. All right, this is where I wanted to spend some time with us right here to actually look at these peripheral nerves and how they run. So what I've done is I've got a table here that lays out, sorry, I'm making you guys dizzy as I try and do this. I've got a table here that lays out each nerve and what it supplies. So we can see the suprascapular nerve all the way through. I've also got spinal levels that lay out what each supplies. I've talked about the brachial plexus really quick, but I don't want to talk about the brachial plexus like this. I want to play for you guys a video of the brachial plexus on a cadaver dissection so we can actually see what this looks like. When's the last time you saw a cadaver dissection? Give it in the comments. Give me a comment on when's the last time you saw one. In school, 2009. Yep. Okay, it'll take me a second to pull this up, but I want to talk about the brachial plexus here really quick. Unfixed and fixed. All right. 1979, woo, that's a while. All right. I was 3 years old in 1979. Fantastic. Okay. One of the things I think is highly usable for everybody is going back and actually doing a cadaver dissection. If you could go back and look at it, I think you'd be, especially as practice clinicians, you'd be surprised how much your viewpoint has changed and how you'd look at it and say, some of the treatments I'm doing now, ooh, maybe that might not be the best treatment, or you can see how you could have effect in other areas. Okay, so I'm going to play this video. Please, a ton of questions. Ask me anything on this. Stop and unmute your mics if you want to ask anything. I have a ton of videos, so if there's anything specific you want to see, I can take requests for us to do this. Most of us haven't seen a brachial plexus or its relation to the scalenes, but this is one of the things that I like to do, and especially now because you're clinicians, it'll make more sense. But we are going to screen share this screen, I think. And give me a second. Okay, is everybody looking at a cadaver dissection right now? Good. Okay, so this is a dissection. Yeah, well, you guys can look at it. This area, this muscle coming down, running off of the below the hyoid bone and thyroid cartilage, coming down and out to the shoulder rib. Just shout out the muscle names when I say them too, right? So that one is coming off, going down to the shoulder is, of course, omohyoid, everybody's favorite, omohyoid. Probably haven't said that since school, but that's okay. Omohyoid. So we can lift omohyoid and push it a little bit out of the way. Here I can see the anterior scalene muscle and the middle scalene muscle. And if I peel the clavicle back and down, I can see those a little bit better. Some of the subclavian vein is running right through here. These are the roots of the brachial plexus. Let's stop right there. Can you see how big those roots of that brachial plexus are? They are freaking huge, right? Like, look at the size of this. That is the anterior scalene right there. This is the middle scalene behind it, and that is the posterior scalene. The brachial plexus is bigger than your scalenes on most dissections. How many of you work on scalenes when you're doing a little bit of soft tissue work for your patients? Maybe a little bit of lean out, okay? I'm going to suggest to you that you're actually working on the roots of the brachial plexus. Does that seem pretty obvious right there? I'm going to stop the screen share for 1 second here, if I can. Don't know if I can. Okay. Stop the screen share. How many of you were aware of that? The size of the brachial plexus in relation to the scalenes, right? I mean, that's an honest thing right there. So one of the things that I really promote, and that's why everything that I'm doing is now anatomy assessment action, is going back to the roots, go back to the common language of medicine that we all learned of the basic anatomy and realize the variations that are really out there. It's not that the treatments we're doing are wrong. It's what you think you're working on that might be incorrect. Okay. It also shows you how strong nerves actually are. What does that mean? If you're working on the scalenes and push, you just go lateral to your SCM and start pushing into those scalenes, we don't get symptoms with that, right? How many of you have numbness and tingling when you push on those nerves? It means you have to have fairly significant compression or a multi-crush injury before you're actually going to get symptoms. Nerves are far more resilient than you realize. Okay. Most of your body is more resilient than most people realize. Okay. All right. So I'm going to go back. I can see, turn the sound up. I will do that. Turn the sound up for sure. Back to the screen share. Find this. Where is my audio? It is up. All right. And play.
As they come out between the scalene muscles. So clinically speaking, when you're palpating on a patient, what do? SCM has been cut away, but would have been sitting right here. I roll off of the lateral margin of SCM and sink into this area, and I automatically reach the anterior scalene. I roll a little bit more lateral to that point, and I am over top of the brachial plexus. Look at the physical size of the roots of the brachial plexus. So we'll take this SCM away. The roots of the brachial plexus are as big as the anterior scalene muscle. Okay, can you see how big that is? So a lot of
Can you see how big it is?
Is the brachial plexus. Then you can go ahead and see the middle scalene here, and then still hidden by its fascial layers, maybe the posterior scalene back from there. What else do I like about this dissection a lot is the fact that you can see the clavicle pushing down right on that brachial plexus. Can everybody?
And just wait, so that's something that we can take into consideration too, right? A lot of us are seeing kids or well, even adults as well, carrying heavy backpacks. So what can you do? That clavicle pushes right back down onto that scalene. The test for that would be called a military brace test or costoclavicular maneuver, where you have the person lift their shoulders up, rock them back, and then bring them back down and see if that clavicular compression can aggravate symptoms, or they may have had a broken clavicle before where they got a callus formation over top here. But regardless, this is something you can modify. That's a modifiable factor for compression of, if that's the cause of brachial plexus compression.
Visualize that as a site of compression. What else do I see fantastically done in this dissection? The pectoralis minor muscle coming off of the coracoid process could also compress down onto the brachial plexus. Okay.
Now, I do need to make comment on that. Pec minor can compress the roots of the brachial plexus too, but pec minor really is only involved when you go beyond about 90 degrees of shoulder abduction. If you're below 90 degrees of shoulder abduction, there's actually more space underneath pectoralis minor. But once you get above 90 and start stretching up higher, then that's when you can see positives for pec minor being involved. I'm going to take the arm here and move it up, and you're going to see tension on the nerves. This is golden right here for all of us. If you get nothing else for this, from this whole seminar that I'm giving you guys, you need to see this part right here where you see how nerves stretch as you move them. Okay.
If I peel back the deltoid muscle, what do I see? This is going to be the head of the humerus right here. Running to the coracoid process is the short head of biceps brachii and coracobrachialis. We peel that back, we can see the nerve that runs through coracobrachialis, which is the musculocutaneous. I peel back the pectoralis minor muscle, and now you can see the more of the neurovascular bundle that makes up.
It's just like Netter drew it, right? Isn't it? Okay, it's got these nice 5 branches that all fan out and yada, yada. No, it's not like that at all. What is it? It's a 3-dimensional structure that actually wraps around the brachial artery is what it is, and quite a bit bigger than people realize.
The brachial plexus. Brachial plexus here, this is going to be the subclavian or axillary artery and subclavian or axillary vein at this location as well. So I just wanted you guys to see that. Maybe if you're looking at a right hyperabduction test or a ruse test or an arm elevation test, when you take the arm and you bring it up, can everybody see?
So this is the key thing to get right now is when you start to pull the arm above 90 degrees, okay?
Oh, excellent. Look at that. So you see how the nerves have no tension on them right here? They actually fold back. As I bring the arm above the head, what happens? Tighter, 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 all the way across like this. So this sternoclavicular joint needs to stay attached, but you can see right there how these nerves could potentially be pulled underneath pectoralis minor as you abduct the shoulder blade.
Okay. Every nerve tension test that we do, straight leg raise, brachial stretch test, it's all the same. When you go to move like that, you are lengthening and stretching out those nerves and looking for reproduction of symptoms. So I wouldn't look for pec minor as a major player until I got above 90 degrees. Otherwise, there's next to no compression right there. And a lot of people jump on pec minor right away as a major site of compression. It can be involved, but it's not not the only site.
So here we're at about 90 degrees of shoulder abduction. If I go all the way up and dislocate the shoulder a little bit, okay? So we go all the way up. Can you now see the tightness underneath pectoralis minor? That's perfectly what you do.
All right. Cool or super cool? Okay. That is super cool right there. That little ditty. Okay. Questions on that? What do you think? How many of you have seen that before? Todd, have you seen that before? Nope. Okay. Direct relevance to practice, that piece of information right there. Okay. Direct relevance. Who else can smell their cadaver? Yeah, a lot of people can smell their cadaver right now for sure. That's one of those memories that never goes away right there. Okay. So, yep, good comment. Definitely. All right. So think about that every time you're moving somebody around. Now, so that's one that I can show you. Let me go through a little bit of the nerve pathways here a bit. And then I want to show you one that shows movement of the neck and the meninges. Pretty cool for us to see. So if you're doing a dural slump or lumbar range of motion, all of that, we can see it. Okay. Or we're on to hour 2 here. Do we need to take another break? That's a good question right there. So let's even do it with this, this little slide right here. So how often do you see brachial plexus conditions directly from the scalene involvement? This image is from Gray's Anatomy of all places, where you can see the scalenes coming down, brachial plexus and all of that. But what I want to talk about more specifically is differentiating other areas, specifically scalene involvement by itself, not overly common. Okay. Unless the person has like they have a lot of anxiety attacks and there's a lot of tightness around the neck. I typically don't see it, maybe in some severe whiplash cases. But the thing that I want to go over is these pages right here that kind of take us through like radial nerve, musculocutaneous, and more specifically, the median nerve in this case. And the big thing for you to get off of this is when I'm assessing somebody, I go down my list of what do I have to check for areas and sites of compression. Well, I've laid it out here, what you see for different areas and supply for them. But if I zoom in on the very bottom here, here is my list if I think you have a median nerve problem of what I would go through. So the first thing I would check is the IVFs. I would look at your spine and see, do you have compression symptoms there? And if you have compression at your IVFs, though, the question we should be able to answer is, what type of symptoms do you get if it's intervertebral foramen compression? And if it's IVF compression, the symptoms are going to be unilateral, dermatomal, myotomal distribution. Okay, if it's an IVF. But if it's the scalenes, or it's the clavicle pushing down, or it's pectoralis minor that's got some tightness, or it's pronator teres in this median nerve case, or the carpal tunnel, now my symptoms are very different depending upon where that compression is. Or what really happens more likely in practice is maybe it's a little bit of scalenes, maybe it's a little bit of the clavicle, maybe it's a little bit of pronator teres and the carpal tunnel. I can't tell you how many surgeries I have helped people avoid by doing a detailed assessment of the peripheral nerve pathway. And if I could give you one thing to take home with this, it is that detailed assessment is what is required to make sure you get good outcomes for people. So what is involved in a detailed assessment? Well, let's go through really quickly here, and we'll just take the median nerve because it's the most common example. How would you go through, just thinking in your minds right now, how would you go through and actually assess a median nerve, the median nerve pathway? I'll give you my quick go-tos on this that I'll do. So first of all, as always, it's an upper extremity issue. I'm going to start with just neck range of motion. See if that aggravates symptoms or makes them feel better or worse. Then I'm going to progress into, if it's warranted, I might do shoulder range of motion or something like that, but usually I don't, but sometimes I will. Okay. Then it's going to be palpation, right? You're going to come in, you can look at the area, then I'm going to palpate the scalenes. I'm going to palpate the clavicle, even take that clavicle, grab your bone, man. Okay. Take that clavicle and even squeeze it. One of my favorite tests is to actually take a clavicle like this and interlock my fingers and just squeeze the clavicle down into the shoulder and see if that aggravates symptoms. If they have any kind of AC issue or anything, that'll show up. All right. Then you can go ahead and palpate around pectoralis major or pectoralis minor and running down the arm. Now we know that the median nerve runs between your bicep and tricep down the arm. So why not even just palpate right there and see if you have any symptoms? Then continuing down, I'll get the doorbell sign in just 1 second. Then I'll come down to the pronator teres. You are not doing a median nerve check if you do not palpate pronator teres. For the basic anatomy here, just to remember, the pronator teres has two heads, a superficial and a deep head, and the median nerve goes right through in between those. So if somebody has a lot of tightness or weakness with pronation, this is another potential site of compression. And then, of course, you're going to finish off in the carpal tunnel. Tunnel's test is a great way to go. Okay, Tunnel's test is going to be a good test there. Or even again, people tend to hit too light, even consider using your reflex hammer there, and then flexion and extension, or you can do, what are you going to call it? Phalens and reverse phalens or prayer test. Okay. So how accurate is the doorbell test? Not very accurate unless their symptoms are extremely obvious. Okay. Extremely obvious, extremely acute, I guess I could say. So if you take in and just push on here and they don't have symptoms, that if they do have symptoms, it's great because that tells you right away, this is probably a major player. But most people that I work on with this test is not positive, right? Again, what you have to visualize in your mind is a multi-crush injury. It's a little bit of compression here, a little bit of compression here. Maybe pec minor is okay. And then maybe it's a little bit on the forearm, a little bit here. Maybe they have some stenosis and neck tightness. So our treatments, our assessments need to be like our treatments, and they are multifactorial in nature. You're doing a way better job if you check the entire pathway of the nerve than if you just wind up just trying to rely on one or two tests. And really that exam, it doesn't take that long. People think it takes a long time, but it doesn't. It only takes you about 5 or 10 minutes to do that. And you've heard me say it at the very start, your assessments are therapeutic. People will respect you better and understand your knowledge base better if you go through that full assessment. One of my favorite sentences that people say, well, my other doctor didn't do that. Okay. How many times do you get that? Right? Or my other person didn't do this, whoever it was, another therapist. Well, my physio didn't do that. That's exactly what you want to do. Establish your expertise again, especially when you're dealing with these more difficult cases. All right. So doorbell test is pretty low on my list. You want my best test for a brachial plexus injury? I've already shown it to you guys. My best test for brachial plexus and all the upper extremity nerves, well, that's not true. For the median nerve mainly, is a brachial stretch test. It is by far the best test you can do. Why is it a good test? It is almost exactly the same. It's analogous to a straight leg raise test for the lower extremity. So what do we have? We have excellent research on the straight leg raise test and how it works. So I'm just going to review a brachial stretch test really quick so you can all start applying it in practice. I like it because the assessment is also therapeutic. I am actually stretching the nerves out at the same time. I can give it to you as a rehab exercise. You can even do it yourself, all right, as the patient. So what is the process? You have to make sure you do it correctly. And I should actually say this for everybody too. For anything that I show you here, if you go onto our website, I'll show you at the end, we actually have videos of all these tests where I show people how to do them, what are the common errors for them, what's your interpretation. The Canadian Chiropractic Association is actually, we've had a couple of meetings already. They're looking at making this mandated for their members, actually, as membership to our website, so you can see all of it. But I'll show you guys at the end the website. You'll be surprised what's there. It's been a journey of 20 years, but it's got some good stuff. But more specifically for you guys right now, with the brachial stretch test, the process is always least invasive to most invasive. The same thing for your treatments, least invasive to most invasive. In fact, I'm dropping all the gold here for you guys right now. What do I really think when I'm working with somebody? I think in terms of first principles and minimal effective dose. What is the least that I have to do to help you? Minimal effective dose. Write it down. MED. It's one of the things I talk about in all the books now. Minimal effective dose. What's the least that's going to be the tipping point to make a transition for you? So if you're going to use the brachial stretch test as a way to assess somebody, starting off, number one, make sure I can see myself fully in the screen. Just have them lift their arm up and try and straighten it out. And I'm just in my regular plane right here. Can I bring my arm up like this? Yes, they can, no problem. Then I'm going to go ahead and say, can you bring your shoulder back a little bit? This bringing of the shoulder back into extension already puts more stretch across that front of the brachial plexus, okay? And then I'll ask them to go ahead and stretch their wrist back into extension, all right? You will go wrong with this if you try and take the person into it right away and they jolt themselves and they're like, oh, that was really sharp, okay? At any time when you're doing this though, you're gonna see them and they'll maybe move their wrist back and they might flex their elbow. If they flex their elbow, that's the same as a straight leg raise test when the person flexes their knee. They're trying to take pressure off of the brachial plexus. All right, but let's say you get to this point, and those of you who are doing it at home right now, you get to the same area. Check my mic out here. Chunk. Oh, my camera angles are all off, but that's okay. So what do? You get back like this into the extension, the elbows back as well. You bang into your TV behind you, and then you lean away from it. And if you're doing this at home, you can feel that stretch right away. Okay, if your arm is behind, this is the start of nerve flossing right here. This is you stretching that nerve out, taking the pressure off, stretching that nerve out, taking the pressure off. Now, if it's really a nerve issue, what you should get is a reproduction of numbness and tingling or some kind of shooting electrical pain, right? But the other thing that happens, I got to do the other side because I feel out of balance now. We should all do that, okay? All right. The other thing that happens with this though, is sometimes you'll do it, like all of you who are watching, you're going to feel it in different places. Okay. Some people are going to feel it as numbness and tingling or shooting down their arm. Some people are going to feel it more of a pulling sensation or a fascial tightness. Either way, it's still a win. Okay. It's still a good test because I'm challenging your fascial tightness to give you more mobility with this, or I'm stretching the nerves out of the same, or the blood vessels or the muscles, whatever you want to say. It still winds up being a movement that offers benefit to the patient. Okay. So I think that is one of your best tests that you can use for these upper extremity neurologic conditions. And I would use it as well, we've all seen this stretch, right? Where you put your arm on the wall and you lean forward like this and everybody's, well, that's a pec stretch right there, right? Except that when you're thinking about anatomy, you need to think of all the things you're moving at the same time. That stretches nerves, blood vessels, that stretches out lymphatics, you name it, it's fascia. It's all getting stretched with that action, okay? All right, the next test is gonna be that cervical compression test that we already mentioned. And just a review on that one too, great test, good research on it, good findings with it. Again, least invasive to most invasive. So how do we start? Just a straight up cervical compression where you've given good informed consent, you've demoed to the person, I wanna put my hands on your head, I'm just gonna pull down like this and I wanna see if you have any symptoms with that. Now, most of you are experienced, so I don't expect this is still an issue, but what I see for a lot of junior practitioners is they're actually too light. They don't push hard enough, okay? So the process there is, I'll add a little bit to it for you, is to get the person to take a big breath in to begin with. So they breathe in. And then as they breathe out, that's how I give my load. I start loading down, 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 and I'm looking for any reproduction of symptoms. So as you load down, and I'm almost giving like a lot of body weight by the time that I'm done, that gradual load for symptom reproduction. You will miss symptoms if you don't do the tests correctly, or if you do them too lightly, right? Like we know this. If you're looking for biceps tendonitis as a simple example, or a Tinel's test, let's even do a Tinel's because we're doing a neuro class here. If I do Tinel's like this, well, guess what? Technically, I'm moving my body correctly, but am I actually hitting hard enough to initiate symptoms? No. So you might as well not even have done the test because it's invalid in that case. So I could start off nice and light, doing okay, a little bit harder, and then work your way into it. All right. When I do a cervical compression test with a patient, what I'll actually say is if they took a lot of load, I'll say, yeah, you took a lot of pressure with that and it didn't exacerbate your symptoms. That's a small victory right there. That's showing them, changing the mindset that, you know what, maybe it was a whiplash injury or whatever caused it, that your body is stronger and more resilient than you think it is. Okay, that was a good finding. And I'll say that for all of my tests. I'll say why I'm doing it and why I think it's a good finding. And especially because I treat a lot of therapists and doctors as well. is I will have a high level discussion with them and say, hey, what is this doing? What are we actually compressing? And mention the anatomical names. Again, establish your expertise. Write it down again. If you wrote it at the very start, write it down again right now. Establish your expertise. Brett, write it down again. I can already tell you're an expert, but write it down again. Establish your expertise. My biggest pet peeve for us is this. How much did you spend to go to chiropractic college? We are talking at least 3 to 4 years of your life. Yes, too much, okay? At least 3 to 4 years of your life, and potentially in the realm of what it would be in today's dollars, hundreds of thousands of dollars. You basically spent a house to go to chiropractic college, probably, okay? Somewhere around that. Yeah, laugh out loud in US dollars because I went to US too, but absolutely. So what happens is people forget to apply all this information that they've gotten, that they've paid thousands of dollars and years of their life for in front of patients. I would suggest to you, it's in your best interest to actually, don't go crazy with it, but to actually name drop and say, what am I doing? I am going to compress your discs and your cervical vertebrae. This action right here, I'm stretching out your brachial plexus. Just a few catch key words that are going to be in there to, again, establish your expertise. Okay. All right. So those are my go-tos right there. And then you could get into more specifics if you wanted to. And so Phelan's test, because we're talking about the median nerve, Phelan's test could be another example of a test that you might do. But I don't think Phelan's test is good enough by itself. You have lots of different ranges of motion for wrist flexion and everything like that. I have these very feminine wrists where I can basically bend 90 degrees. When I'm doing jujitsu, it's nice because I can reach around and grab people in different ways, but look at how much these wrists bend. I get 90 degrees out of them. Well, you got a guy who comes in who can only bend their wrists about this far, right? So the test doesn't have the same compressive load over top of the carpal tunnel. So what I like to do is I like to push them into that position, almost like a wrist break, like you're holding somebody in an MMA wrist break, but you're not pushing super hard. And then my finger goes in at the same time, and I also compress the median nerve, okay? If the problem is really at the carpal tunnel, this should be a way to exacerbate the symptoms. It's kind of like the idea of the doorbell test. If this is really the location of pathology, well, if I can push on it and it goes ding dong, symptoms, then it's a good finding. But if I push on it and it doesn't give me symptoms right away, I know that I need to look other places, okay? Anything we do, if you can get symptoms like reproduction of symptoms, it's one of the major findings that tells you right away you're in the right place. I mean, even something as simple as palpating a low back. If you push on the spinous processes and you're doing a little P to A challenge with them and they have deep back pain, now I'm thinking ligamentous disc injury, right? But if they don't have pain with that, but they have pain when you push on the muscles, well, right away you can push it into a low back sprain strain. You talked about checking IVFs. X-rays, yes. X-rays are warranted for IVF evaluation, but I would only do that if the case history looked correct for it. Like we know the research is pushing hard into this direction. I'm going to show you guys some of the memes right here that I'm making. Like if you follow me on Instagram, I post this stuff all the time. Let me find it here. For X-rays and the value of diagnostic imaging. The value of diagnostic imaging seems to be dropping lower and lower as time goes on. And the reason for that is unnecessary, well, no evidence behind the imaging that's taken, but also, just give me 1 second here, but also the number of false positives, right? Or false negatives, however you want to say it. But there's a specific meme I'm looking here for you guys that I want to show. Bam. This is one I posted last week. Got a whole new format for what we're making right here. And I will do a share screen with you right now so you can look at this. X-rays are good to look for IVF encroachment. Absolutely. You're going to be doing your oblique views, standing off to the side, and you can look right down the IVFs. I talk about that in the booklet here. But does everybody see this abnormalities found on asymptomatic patients? Everybody sees that right now? As one, take a picture of this. Okay. Ooh, wrong one. Can I zoom in? Make it even a little bit bigger. Okay. Most of these studies are systematic review meta-analyses. This is high quality research right here that's giving these numbers. And the biggest thing that I'll say for everybody is treat the patient, not their pictures. Treat the patient, not their pictures. If you look at a radiology report, what is that? That is somebody's interpretation of a picture that they saw. Well, let me ask you this. I ask us all to describe a picture of, what is it going to be? Everybody describe this for me. Okay, I'm holding up, what is it? It's a model that shows the lumbar vertebrae and everything. This is from Dynamic Disc Designs, Jerome Fryer, who does these. Describe this for me. Well, how I describe it, how Cheryl describes it, how Brett describes it, and Francis describes it, it's different from one person to the next. I've got a study that I quote fairly regularly as well that had one person, the same person went to 10 different MRI suites and had 10 different MRIs done, and no similar findings were found. Different findings on every single MRI report that was given. Okay. The value of imaging is becoming more apparent to be less valuable. And even if you looked at that Hypners I gave you at the very start, the value of imaging is in the S. It's in the special tests right there, right? So it's a lower value item for you unless they have the right history. And what's in the right history? You have had prior neck injuries. You are more likely a geriatric or older patient population where I have to rule out stenosis secondary to osteophyte or osteoarthritis growth in that area. But at the end of the day, guess what? Your treatments are probably still going to be the same, right? You're probably going to still adjust this person. You're probably still going to work on flexibility and strengthening exercises. The treatments are probably going to be the same unless there is a huge osteophyte or some kind of surgical intervention that's required for it, or in the extremely rare cases that you actually have a cancer or something else growing in there. But otherwise, it's going to be the vast majority of people, it's not going to be a significant finding. This graphic, pretty cool. Like, it's kind of neat to see that. And these aren't small studies, right? These are studies of like 1,200 people, of 3,000 people, 2,000 people. Like, these are, these knee abnormalities. This is from 2020. Seen in 47 to 97% of people with asymptomatic knees. All right. Pathology on imaging does not equal pain, or sorry, variations on imaging does not equal pain. All right. We know there's a poor correlation between what you see on X-ray and how the person presents. All right. Is that news for people or not? No, most of you guys have seen that. Yeah, good. Okay. The point is to get that out there. Well, what happens right now, whenever somebody goes, it's a frustration that I have right now is you see a lot of patients go into like the ER or whatever it is, and the doctors don't even do an exam. It's like, I can't do anything until a CT scan is done or an MRI is done. Well, that's garbage medicine right there. We know that our physical exam skills are as good or better than MRI. And well, there's another one that I've got here for you guys too. That is, yeah, this one I just posted up on my Facebook page, actually. Let me just share screen this here really quick. It is one that talks about imaging and actually making people sicker if you read the imaging for them. So don't judge a doctor on this. Yeah, you got too many pictures here for you guys to look at. Muscle strengthening facts, informed consent. Regardless, I can post it up if anybody wants to see it. I got to go through too much stuff here to find it for you guys. But what it is, oh yeah, that's right. I just made it this morning. That's why it's not here. Yeah. So what it is basically is that long-term people with chronic low back pain do worse if you give them MRI findings. It gives them scary words that they fixate on, and then they don't actually get better. They have worse outcomes. If you focus more on clinical findings, which is what I'm trying to promote here, if you give them clinical findings that you go through as you're doing your exams, the outcomes are better. All right. Yeah, that's absolutely right, Mike. You're saying that right there. You find that imaging findings hinder patient progress? Absolutely. Because what's an osteophyte? It's a big, scary word. I don't know what that is. And then I go and Google it, and I see an example there of the biggest one ever. And it's like sticking out of the side of the person's neck. It's so big. And I must have cancer is the next thing, right? Yeah. Yeah, exactly. The CT scan, believing their career is over. This is too common of a story that we actually get right there with this, right? So what you want to do is you want to actually say to people, these are normal findings. We're all going to get this later on, and you can lead a normal, healthy life. What do we actually do? Cinnamon bun hands, get them out. Okay, get your cinnamon bun hands out. Shannon, I'm talking to you. Yes, we can. I can get you moving and I can get you better. The treatments, as long as there aren't major red flags, are mostly the same for most people. Yeah, common interpretation. I have arthritis. That's why I have pain in my knees and shoulders and low back. Absolutely. And we need to break that cycle. That graphic that I just showed you guys, I'll send it to you at the end here, Francis, so you can share it with all the members. It's a great study for us all to look at. Okay. Well, great multiple studies for us all to look at. All right. And it's a matter of educating the public and educating other doctors as well, who are still stuck on the imaging mentality of the central crux for their treatments. Okay. All right. Fantastic. I like it when I'm preaching to the choir here. Okay. Everybody's like, yeah, yeah, yeah. Rah, rah, rah. This is what evidence-based medicine is. Right now in BC, we actually have litigation going to the Supreme Court of British Columbia from a group of chiros who want to x-ray every single patient that they come in and do their measurements off of. And I guarantee they're not going to win. They're not going to have good evidence for that. So, yeah, it's going to, you're seeing there's a transition now, especially at least in Canada, towards evidence-based practice. All right. There's a lot of stuff that I can show you guys here, but to make it as relevant as possible, I just want to finish off this nerve stuff for you really quick. So where I am here, I'm just going to finish off the neuro chapter is, this is just a reminder, just of areas that you want to look at for different nerves. By the time you see atrophy or you see this claw hand or bishop hand, you're late stages of this condition, right? It's been there for at least 6 weeks or probably longer. And it's going to take longer for them to actually heal. All right. Yeah, same thing for axillary and radial nerves, all of that good stuff. You can identify those. But where I want to spend a little bit of time is on these lower extremity ones. And in particular, the one where we should spend our time is the sciatic nerve. All right, so there's our picture of the sciatic nerve. A couple of key things to get. Number one, the Piriformis has multiple variations on how it attaches. I love the study I pulled this from because it was over 2,000 limbs. And you can see that there's going to be variation that how that nerve runs. So that's the first thing to explain to a patient. Say, there's going to be variation with it. But my go-to tests for this one, if you're going to pick an orthopedic test to perform and make it assessment, trying to zoom in as much as possible, is this test right here. What is the name of this test I'm showing you on the picture? Yep, I heard you say it. I heard you say it, Francis. It's a dural slump test is what people call it. Okay, it's called a dural slump test. But in fact, what is it really? It's the equivalent, like we've just talked about, of the brachial stretch test, of a straight leg raise, of a maximal straight leg raise. Because if you took this person and laid them on their back, you would see that you're moving in the same direction. So let's make sure that we understand the process that we would go through with this. I'm going to stop my screen share right here and just go into it. Okay. This is one of my go-to tests for the lower extremity. So you guys are going to get to see this is my Burnaby clinic space. I do things a little more aggressively in here. So also, if you're ever here in BC and you want to do some jiu-jitsu, I got about 600 square feet of mats where I roll with a bunch of doctors and therapists. So a couple of key things for us to get. First thing is, for this test, you're probably going to start off with something as simple as a straight leg raise, but don't go there first. I'm going to suggest to you that a better version is going to be just bending forward to touch your toes, because the angle at the hip is the same if you bend forward to touch your toes. So keeping your back straight, in fact, let's all get up and do this. You guys have been on your butts for a while. Let's get up, stand up. All right. So I'll take this off so you can see transition better for the different colors here, but what do? So how does it start? It starts like this. So patient comes in, low back pain, maybe positive Valsalva. You're looking for all this stuff along a disc herniation. So I'm going to have you start and bend forward like this. And I'm not even going to say touch your toes. I'm going to have you keep your back straight and even put your hands in front of you, because we know how most people move with this. They actually want to support their back. They'll grab their pants. They'll try and walk down like this and watch them bend down. This is the same as a straight leg raise. Let's all do it. Just bend forward. Keep your back arched into extension and stick your butt out. Okay. And as you lean forward like that, can everybody feel the stretch on your hamstrings, right? That should be a mega load on the hamstrings right there. So I'm going to change this just a little bit so we can scroll down here. I know you guys can, now you guys can see my ring light and all my beautiful lighting that makes me look so pretty, right? I knew you were thinking about that, Todd. How is he so pretty? Yeah. Okay. But what you want to look for on this test is this. You want the person to bend forward, and as they bend forward, their knee is going to flex forward too. Why did their knee flex forward? Okay. Their knee flexed forward to take pressure off of the sciatic nerve. So start with them standing, see what they can do. All right. Beyond that, you can have them, and I've had patients do this in acute cases. I'm like, so they go down as far as they can, and you're like, is that as far as you can go? Yeah, I can't go any further. I'm like, well, what if we had you walk down a little bit further? And I know this is crazy, and it might be difficult for you to push a patient a little bit further, but I've had people walk down like this. Symptoms come on, and then once they get past a certain point, they can hang down and they'll be like, oh, now I don't have symptoms anymore. Okay. And then they'll come back up really slowly and have to walk themselves back up through that painful area again. How many of you have had a patient like that, where you've had them in an area of pain and then you get them past it, right? If you do that, the patient has already improved their range of motion. They've stimulated nerves in the area, and they've also told you how they want to be treated. Spinal distraction is going to be a win for that person. And because they've done it in a safe place in your office, you can probably get them into that deep flexed position again and encourage them to do that themselves. Now, that's not going to be for the ultra acute back case, but for the standard cases, I found pretty good success with that right there. Okay. Questions on any of that? Have most of you tried that, like pushing people that far into it as much as we can? It's a scary thing to do sometimes, to do it. And of course, you have to listen to the patient. If it's too much for them, that's where you stop. But that movement is going to be a win right there. Okay. All right. Then we'll go back into our pretty standard stuff right here, which is going to be a straight leg raise test. But you know what I'm going to do? Let me just move some things here. Get set up. All right. So now you've got your patient, you've gone ahead, probably you've had them seated, maybe you check their reflexes. Reflexes were down a little bit. Maybe, yeah, you're just in the transition of getting them to lay down. Maybe, in fact, this is such an acute low back that you do have to lay them down so they're actually comfortable, right? So you have them lay down, and when they're back in this position right here, everybody can see me? Yep, totally. Okay, good. When they're laying down like this, there's nothing more to do than have their knees bent, keep them comfortable. I have done full physical exams with patients in this position. One of the first things that I like to do is always attending to patient comfort. So you can check reflexes in this position. You can check motor strength in this position. It's all available for you, right? So one of the key things that I'll do here is I'll go through the parts of a straight leg raise test. So let's just say the person, because sometimes they're so acute, they can't even put their legs down. They're not too acute, and they kind of lay down like this. You can get them straight. So you're going to go ahead and do your straight leg raise, right? So you'll do your straight leg raise, get them up to here, numbness and tingling, no numbness and tingling. But what if it's not ultra positive? How do you increase the pressure? Well, you do exactly like that picture shows you right there. You switch over to a maximal straight leg raise. So leg raise comes up. You can do your Braggart's test for dorsiflexion. Aren't these shoes perfect for this? Okay, you can really see them. All right. Have the person lift their head up, curl them right in like this, and then say, can you cough? So what am I doing? I'm giving you application of the basic theme we've already seen. I am going from least invasive to most invasive. I am trying to put maximal pressure on you right there. And I'm using it as a way to, well, number one, assess, but also as a treatment. Because what am I doing in that position? I am stretching you out as much as I can. All right, I'm loading into that as much as I can. But wait a minute, it doesn't stop there, boys and girls, because what else do we need to recognize? I'm in this position right here, all twisted up. Watch this magic. What is that the same as?
Slump test.
That is exactly the same as a dural slump test. So it's your choice. If the person, the advantage of the dural slump test is now I have gravity pushing down their spine too, versus a straight leg raise. There's no gravitational load on the spine, right? And let me just make a comment on that for 1 second. If you're looking at MRIs, the problem with MRIs for disc herniations is the vast majority of them are done supine. The spine isn't loaded when you actually have the MRI. So even the accuracy of that image is going to be different than in a hot disc where somebody's standing up because of the load onto the spine. Okay. All right. All right. What do we got? We got somebody else coming in on the side right there a little bit. Okay. You guys distract me when strangers come in because it's like stranger danger. Okay. So what do we get here? I want you guys to realize that it's the same motions you're doing between a dural slump test, which is thought to be for dural adhesions, which it can be, but they're pretty rare, is the same as a maximal straight leg raise, but approach it step by step, minimal effective dose and going from least to most invasive. So what do? The process is this, your choice. You can either go bottom up or you can go top down. So the typical way that I like to do it is I'll go bottom up first. So I'll say, hey, can you go ahead and lift your leg out? They'll hold their leg out here. I'll support them under the knee. And then I'll say, can you go ahead and dorsiflex your ankle? Yep, how is that? And in acute cases, they'll be like rocking way back like this. They won't even want to flex themselves forward. All right. And then from there, you can go ahead and flex forward. And then the biggest one to finish at the end is drop the head. Head back up, drop the head. If you guys are at home doing this, do it right now and see what it feels like. Get that leg up, dorsiflex the ankle, and then go ahead and just drop your head. Can everybody feel how you might feel that stretch all the way down there as you do that action? Okay. Mike, you're not feeling it. How can you not feel it, Mikey? Come on.
Can't feel it. I don't know.
Okay. It's not working for me. Okay. All right. Okay. So that's one of the key things that I would go to right there. But what's the beauty of that? Guess what? You use that as an assessment. Why not turn it into a treatment right there? Right? Your choice. You could lift that leg up a little bit more if you wanted. You could just focus on the dorsiflexion of the ankle if you wanted. You could focus on the movement of the spine or of the head and neck. All of that is therapeutic for the patient and diagnostic for you. And again, oh, there it is, Mike. Take it easy. That's somebody else's leg, isn't it? All right. Yeah.
Felt that.
Yeah. Nice. So does everybody get that? Like that's an assessment that becomes instant therapy right away. Okay. Whether you do it standing, whether you do it seated, whether you do it supine, it's all the same motions. How many of you were taught that in school that way, that it does, those three different things are effectively the same thing? Right? We're not taught that. Everybody is taught that this is separate, this is separate, this is separate, when really they all relate and overlap. And that's one of the reasons I love teaching is just connecting those dots together. And even for you, for the people watching this, if you can connect those dots for me too. Yep. Do you actively get patients to do all the actions of a straight leg raise? Generally, I would suggest as part of my least invasive, I'll do my functional assessment to start with. So even if you have an acute disc herniation, there's two key things I'm going to have you do. Well, number one is going to be, because we're focused on the lumbar right here, but it'd be the same for cervical. I'm going to have you do lumbar range of motion to get a baseline of function and also start to warm up the tissue. I'm also going to have you do a squat. A squat is a good functional lower body test. And I would recommend, well, let's even make this simpler. So I'm going to go on the squat spiel here for a little bit. It doesn't matter what your toe angles are. It doesn't matter if your knees are going over your toes, all this kind of stuff. What matters is, can you actually do the action? Your ability to perform a squat after the age of 55 can be correlated with your life expectancy. Okay. There's a great study out of Brazil from over 2,000 people that they did with this. And if they were able to squat and then get themselves back up, their chances of having falls and significant negative outcomes within the next 5 years and dying were substantially lower because of their ability to squat. What's the problem right now? Everybody's got their butt in a chair or they're sitting on a toilet and they're not doing their morning squat like humans were meant to do. Okay. And if you want a funny video to watch, you should go onto YouTube and type in squatty potty. Okay. Squatty potty. It is hilarious. Absolutely funny. Totally true. So do you actively get patients to do the straight leg raise? What I do, first of all, is I like to do it just passively. In fact, if I was really doing it and I wanted to rule out a hip issue, what I would do is I would do not even a straight leg raise. I would bend their knee in more of a Lasag's test and then move up into the hip and make sure everything was okay there, bring the leg back out, straighten it up, and then rock up and in. But it's your choice. Like, I mean, whatever finesse you put onto it is anything that you want. Okay. But at the end of the day, you have to think about what tissue am I stressing? You're stressing multiple different tissues. But what I want to show you guys now is a cadaver video of this that people don't even realize how much your brain and spinal cord actually slide up and down. When you rock your head forward like this, so even us just sitting here like this and then having our head straight and then dropping forward like that, your spinal cord slides up about that much. Okay. There is a ton of movement on your spinal cord just doing that. Basic range of motion is assessment that is therapy. Yoga is assessment that is therapy. I don't know that I'm talking to the right crowd here. How many of you do any kind of jiu-jitsu or mixed martial arts? Okay, there it is. Nice. Okay, nice. Exactly. Perfect, Brett. Fantastic. You tell me jiu-jitsu isn't forced yoga where you're getting bent around and whatever else it is. It's a therapy. It's good for your mind and everything too. So what I'm going to show you now. Yeah. What do you got, Cheryl? You do it? Are you coming in? Oh, come on. You had me all excited. I saw you coming in like this.
Rock climbing, yoga on the walls.
Yeah, totally. Okay. Yeah. All right. But anyways, what I want to do now is show you guys a video of, let me get out of this here for a second. Oh my gosh. a video of what actually happens when you move your spine around, when you move your head and neck around on real cadaver dissections. So, take me a second to find it. Desktop. What do we have here? Okay, and then the one that's going to be good for you, neck motions with meninges. There we go. Ka-chunk. Takes me 2 seconds. You're scaring me, Brett, because you got pretty decent size. You look pretty tall. You look like you got pretty decent size too. No, I don't know, man. What belt? What belt? Black? Yeah, exactly. So you'd beat me with just your legs. Okay. Yeah. All right. Crazy leg me out of there. All right. Let's go ahead and do a share screen with, well, let's make it with this one right here. And you guys should all be looking at a cadaver dissection. Give me a thumbs up if you're looking at the back of a cadaver right now. Okay, so this dissection is not a quick dissection to do. This takes a long time to get here to make this happen. But what you can see is we've taken off the back of the skull. So this is actually all the meninges around the outside of the brain. And then we're running down this meninges down here. All the lamina and spinous processes have been removed all the way down to the bottom of the thecal sac right here, where the cauda equina would actually exist. Now, how many of you have seen this dissection before? Probably not. It's not typically done in schools, right? So if we go ahead and play this one. So here we have a fantastic dissection that's been performed, truly top notch. How long did this take?
All morning.
All morning, yes. We're looking at probably 4 hours, 5 hours of work from the previous dissections that were done. It's probably longer than that. This was probably more like, what am I going to say here? This was probably more like 12 or 15 hours to get there. And that's with a crew of people working to do this. So it's incredibly well protected. I mean, this is the most sacred part of your body, the central nervous system here. So, all right, I'm just going to walk you guys through it so we can see it. I'm just going to turn the volume off on this and we'll kind of come into it. So what I'm going to show you is what happens when we take the head and neck and we move it around. And the connection is direct right through here. So you can see how the cerebral spinal fluid would run down. What you can't see is what it looks like in real life, where it's way more visual when you see it in real life. But if we take the head, yeah, this is cutting all the lamina away. But if we take the head and lift it up, this is a normal frame right here. So this is you in a neutral position. Everything is in alignment. You're standing upright. And then we're going to see what happens when you flex and extend. Okay. Talking about something else here for a second. I don't even know what, but if I flex, that pull goes all the way down to here and would carry on further down into the sciatic nerve and all the nerve roots running down from this position. Okay. And when you come back up, there you can see how the meninges actually accordion up, how they accordion up in that space. So if you have a patient who comes in with neurogenic claudication, so this is enlargement of the ligamentum flavum, all right, and there maybe have some stenosis or something like that, the general history is symptoms are worse with extension. These people will feel better with flexion. But if I have a patient who feels worse with flexion, now I'm thinking of dural adhesions, or which are very rare, or I'm thinking more of neurocompression secondary to disc issues. Okay, so it's a quick differential that you got from simple range of motion. All right, so I'll say it again. If you're extending and the symptoms get worse, especially if they're bilateral, neurogenic claudication and stenosis is occurring most likely. If you're flexing forward though and the symptoms get worse, now you can go down your dural adhesion / nerve root compression pathways if you wanted to. All right, quick differentials. But regardless, guess what your treatment's going to be? Probably the same. What are you going to do? You're going to have the person doing flexion extension type movements to increase their tolerance and resilience to those actions. All right. You're probably going to have them doing some kind of squats or movements as well, if you can. All right. Yeah. I'm just trying to talk more through that. Do I take the head and spin it? I don't think this is the right one. Yeah, that's basically it. So probably haven't seen anything like that before. Stop screen share. Pretty cool. Pretty cool. So this is the layout. Yeah, if you had the blue book, Francis, back in school, then you would have seen similar content. We update like every 2 or 3 years. Let me just take you through the layout of this. So lumbar instability, facet, disc herniation. This is a big one though, so that's why it's got more stuff on it. Let me go to a simpler one. Like lumbar DJD is actually pretty simple, right? Really. So the layout of the entire book is like this. It's the most common pathologies that you'll see, where I go through the basics to begin with. Basics to start, we define the condition, we look at the pathophysiology. So this is the Kirkcaldy and Willis pathway of looking at dysfunctional, unstable, and then stabilization. Demographics of who gets it. Then we progress into assessment, and this assessment is HIPNRS, exactly what we started this whole lecture with, HIPMNRS. So it's history, what do you find? Physical exam, palpation, motion, neurovascular, and then big lists of differentials right there for each condition when you're looking at it. And then x-rays, what they might show you. And again, I even like for this, I say almost no correlation between the degree of degeneration and the patient's pain, right? For DJD. And then the big thing now, though, is the details on the management for patients, right? Details on management. And then, of course, I am huge now because we just finished this, a whole bunch of exercise posters, what we just did the last 3 years here. So this is showing just some Tai Chi and basic yoga stuff that you might do. But I'm going to zoom out, basic push-pull setup for an adjustment that involves more of a distraction force you might offer for this DJD thing, or OA of the lumbar spine, but we'll talk more about it in disc issues. But before I do that, I'll just show you the posters here really quick. If you're looking behind me, it's because this is where we do a lot of lectures out of here, I'll spin around, shablama blama. So you name it, I've got posters for body ball, yoga exercises, foam roller, body weight, all of this. And we put these posters up on our walls in our clinic. So when I'm with a patient, what I'll actually do is say, okay, you've got some mid-thoracic tightness. I think that this is probably one of the best exercises I would have you do right here. And they literally take a picture of it with their own phone. Okay. The problem is when you give people, if you give them a paper, that's going to be your best win because it's actually going to be part of the environment and they're going to remember it. But when you send somebody an email of exercises or a video of exercises, chances of them doing it are pretty low. Right? But if you can find ways to engage them a little bit more, or again, establish your expertise, why are these up on the wall? Because it shows our expertise in the physical medicine and movement of the body. And it's super quick to say, yep, pick these 3 right here, take a picture, take a picture, take a picture. Right? So that's what I wind up doing with those. Okay. But I'm going to fade into this disc issue for you guys right here. Piriformis syndrome. Yeah. Okay. We can talk about that. That's an interesting one. And in fact, you know what? Let's make disc herniation and piriformis syndrome our main 2 that we'll talk about right here, because they're both really good cases. And we'll talk about how maybe piriformis syndrome is a overdiagnosed pathology. Maybe it's not actually piriformis that's the real issue here. Okay. All right. But let's go into the disc herniation stuff. So I am going to share screen with you. And we're good to go. Okay. So you should be looking at a 2-page spread that says disc herniation for us to see here to start with. And what do I see? I can see the definition. It's a tear of the fibrous annulus, allowing the nucleus to extrude. And a lot of people don't get this, okay? You have to actually tear the ligamentous structure of your disc before it herniates. That means you have sprained your back, all right? That's what you're looking at for the healing times on this. It looks more like a sprain. It's a ligamentous type injury. In fact, even on a more basic level, if we wanted to talk about the primary stabilizing force in your spine, most people don't even realize what it is. What is the primary stabilizing ligament of your spine? Just think about it for a second. Primary stabilizing ligament of the spine. People will often say, doctors and therapists will often say, well, ALL, posterior longitudinal ligament. No, the annulus fibrosus is the primary stabilizer of your spine. So if you have small micro tears in there that start off and eventually herniate out, you are looking at significant issues with the stability of your low back. So the most common levels that this happens at is L4, L5, and L5S1. And we know that just because of the compressive shearing force. Secondary to wear and tear of the annulus fibrosis. It's multiple repetitive loads and deflection and extension. And the steeper the angle of the sacrum, the more shearing force there is across this area. There is also the potential for local inflammatory products and edema that take place right there. And if we look at the stages, you can have degeneration where it starts. You can have a prolapse where it pushes out a little bit, extrusion where the nucleus is coming out, and full sequestration where you get that full bulge. But what I can't tell you is that the sequestration is more painful than the disc degeneration. It varies from person to person. There's a poor correlation between findings on imaging and actual patient presentation. And I know there's an error on this where you see the exclamation marks. In the real book, it's not there. It's an issue with when we do a screen share, it puts those in sometimes by accident. All right. So what are you going to look for? Number 1 to 3% of low back pain cases involve disc herniations. And this is usually going to fall into your younger age group, right? The discs are more hydrated in younger people. As you get older into your 50s and 60s, now you're looking at more stenosis issues because the discs become less hydrated. They become more fibrous. So risk factors are, number 1, by far and away, lifting, twisting event, repetitive lifting, twisting event. All of us have seen this patient almost to a person. You've seen the individual who has hurt their back at the gym doing a deadlift. And that's the starting process right there. Usually it's a heavy deadlift because when they were younger, they wanted to toss up some heavy weights or something like that. So it's a chronic overload of the disc. And you have delamination events where you get little micro tearing and the layers start to separate out a little bit. You can have prior trauma, so falls, motor vehicle accidents can be associated with this. Asymmetrical loading and twisting is another major one right there. Poor postures and muscle imbalances potentially can be involved. Congenital defects where you actually have different shapes on your disc or vertebrae themselves. There is potentially genetic predisposition. If you have a lack of exercise, lack of conditioning predisposes you to this, and weak, poor core body strength can be there as well. So weak abdominals, tight hamstrings, and then poor nutrition and general health. You know, it's all back to the basics of medicine. They're smoking, they're overweight, they have a high fat diet. All these can be potential involving factors. But the big finding is history of sudden onset of low back pain with leg pain past the knee. And that is the big thing, pain past the knee. All right. They often will have prior low back episodes where that annulus fibrosis has been getting torn up a little bit of damage is taking place. And then eventually, if it's severe enough, it'll actually cause pain down the leg. Now you have 2 choices on this too, right? That pain can be back dominant or that pain can be leg dominant, depending on how the body perceives as more pain, perceives more injury to the area. So usually it starts off as back dominant. It's just local low back pain and soreness that's there. But if the bulge comes out big enough, or if there's enough compression on the spinal nerve root, then you get the leg pain being greater than the low back pain. And that's when we see our positive tests right away of positive straight leg raise, dural slump. That Neri Bowing sign was the one that I showed you earlier. So what do I see though? The key thing here to get for this, it is in a unilateral dermatomal pattern. Say it with me with a smile. Disc herniations are unilateral dermatomal pattern. All right. And worse with a Valsalva maneuver. That includes coughing, sneezing, or straining. As soon as I see that, I am like spider sense, all ears for disc herniation on this. It can also be with flexion events, but this is a little bit tricky because people always get tricked on this one. Docs always get tricked on this one. You can actually have a flexion or extension bias. Most people feel worse with flexion and better with extension, but some people feel the opposite. They feel worse with extension and better with flexion. And it varies from person to person. And this is why you're going to want to start in your physical exam with basic range of motion, okay? Seeing how they move. On inspection, you can see the patient will often have an antalgic posture. They'll often lean away. If you'd like to watch a video on this of a recent patient that I had, you can go and type in Vizniak mom disc herniation. And it was a new mom who had a severe disc herniation and was given, what was she given? Narcotic analgesics. She was given some kind of, I forget what the medication was specifically, but she couldn't breastfeed while she was on the medication. The pain was so bad. She had to sleep in a child's pose position. There was all kinds of stuff with it, but it's a nice, simple case. Okay. All right. What else are you going to see? Compensatory scoliosis. That is that antalgic posture where they lean to the side. They may also have back point tenderness. You push on the area and it hurts, especially if you push on the spinuses and do a little P to A glide. You might see local symptoms with that P to A glide. And of course, hypertonic low back muscles, they're going to feel like rocks. They've just locked their back down. It's a tricky thing, but on your first visit, our goal might be to loosen them up a little bit, but not too much. That stability is actually protective at the very start. So you might want to watch how much we do that for. Motion, weak plantar and dorsiflexion. That's where you're going to start off with your heel walk and your toe walk. See how they can do. And again, this is a great opportunity to celebrate those small victories. When you first came in to see me at the start of today's visit, you couldn't even bend forward to touch your toes. And now you can bend forward 10 degrees more than you could at the very start. That's a small victory to sell the patient to go ahead and promote more range of motion with them. Okay. What else? Diminish or absence deep tendon reflexes is a key finding. If it's a late stage injury, you're going to see atrophy of the tissue. Okay. But that's later stages for it. This table, take a screenshot of it, take a picture of it. This is how you tell, is it L4, L5, S1? You would have seen these in school. You can go ahead and take a look at it right here. Deep tendon reflexes for L4, patellar, heel walk, quad atrophy, medial leg dermatome. That's how you can tell right away. L5, hamstring deep tendon reflex, heel walk weakness, minimal atrophy, and then again, along the lateral three toes. And S1 is going to be Achilles loss, toe walk, and outside of the foot. Okay. All right. And then you get into your differential diagnosis, and this is key. Cauda equina syndrome. How are you going to tell it apart? Well, we've already talked about that. You're looking for your saddle anesthesia, bilateral symptoms, bowel or bladder dysfunction. Takes it away right away. How do I know it's not just a low back sprain strain? Well, guess what? If you've got a disc herniation, you actually have a low back sprain strain at the same time. You have strained, sorry, I shouldn't say that. You have sprained the ligaments around the disc. But there could also be spondylolisthesis going on at the same time that's aggravating this. Cancer's relatively low risk on that, but you're looking on the history of gradual progression of symptoms that are not getting better despite any treatment, unexplained weight loss, night pain, all of the weird stuff that comes out with that. Osteoarthritis and RA or ankylosing spondylitis, there's more specifics on those, but those can coexist at the same time. So go-to tests on this are going to be, of course, straight leg raise. Again, symptoms past the knee. Braggart's test with that dorsiflexion where you look for reproduction of symptoms, or the dural slump test, or Koenig's, or Valsalva, or maximal straight leg raise. And this is all in the research right here. When I say we've got good research in straight leg raise, what did we say here? 1, 2, 3, 4, I don't know, 12 articles on straight leg raises as being an accurate test for you to perform. Okay. But the key thing to get is it's only accurate. It's more accurate, pardon me, if the leg pain is greater than the back pain, if it's a dermatomal distribution, if the straight leg raise is limited to 50% of normal. And I should talk about that because we've all got that gymnast patient who can basically touch their knee to their forehead with a straight leg raise. Well, for that person, it's not the standard, oh, symptoms come on between 40 to 80 degrees. You got to bend that person a lot further before you get symptoms to come on. So don't get stuck with these degrees of range of motion. Look for reproduction of symptoms at whatever their flexibility range is. And then they either have to have atrophy, motor weakness, decreased sensation, or decreased DTRs. This is highly diagnostic for disc herniations, and in fact, more diagnostic than the MRIs will be. Okay. All right. And then we get into the diagnostic imaging where you can see MRIs and X-rays. So X-ray might be a starting point for you, but you're not really going to see anything on X-ray other than potentially the antalgic scoliosis, or possibly a slight decrease in joint space height of the disc, but you can't correlate that directly with a disc herniation on an X-ray. MRI is going to be the win for you there. And on the MRI, what are you looking for? Look at this top disc right here. That is a nice juicy disc right there. All the jelly is in the donut. That whiteness is fluid density. Let me zoom in if I can anymore. That whiteness is fluid density. That's what you want to see. But now I lost my jelly. I got no more jelly in my donut. And it's all out towards the back. And these are the regular herniations that we're seeing right there. Okay, so case management, key things that you're going to want to do. Big thing to realize is give that patient those cinnamon bun hands again. Yes, you can. 90% of these cases will resolve on their own. Okay, 90% resolve on their own. So already you take that patient that's ultra excited about this, that's like, oh, I'm just really concerned around this. They have a lot of negativity, and you've alleviated a lot of those symptoms. What else? Educate them on the symptoms of when they need to go to the ER. If they develop any of the symptoms of cauda equina, they need to go somewhere else. The fact that they most likely will not develop those symptoms, another positive outcome for them, right? Our goal is to knock down the inflammation a little bit or support the inflammatory process and teach the patient how to protect and stabilize their back. Another thing you get is looking for centralization of symptoms. When they first come in, the numbness and tingling is all the way down to their big toe. Okay, that's fine. That's our finding. Second visit, now it's only down to the back of their knee. Third visit, now it's only down to the back of their hip. That's one of those small victories that you get. So some centralization of symptoms. Again, Vizniak, YouTube, you can look that up there. I've got a couple of those cases up there. Management, 1 to 3 days, reducing pain, centralization of symptoms, and determining their bias. When a person first comes in, the very first thing I do with them, range of motion, what's better, flexion or extension? And then I have them move into that range that makes them feel, or that they can at least tolerate, and then gradually challenge the opposite direction. Okay, gradually challenge in the opposite direction. And then you have your choice, and we know discs are usually going to respond fairly well to some kind of distraction technique, okay, like anatomical distraction. So I give some recommendations here around flexion distraction if you want, some massage therapy type stuff you can do, flexion distraction movements. But hey, guess what one of the best things you can do is? Have them hang from a bar, okay? They're probably already doing it. When they came into your office, they were probably sitting in a chair, pushing down on the armrests. They're probably walking up and down their legs. In all of my treatment rooms, what do we have? Or sorry, I shouldn't say that. In all of our clinics, what do we have? We actually have hanging bars, pull-up bars in every single clinic. So the patient can actually go ahead and grab on and let their back distract down a little bit, and then encourage them to do that at their own playgrounds or wherever else they are. That low back distraction. Now, the nice thing about that is when they're hanging, if they can really find a relaxed point, is you can have them hang from the bar and then twist their lower body from side to side when it's not under compressive load. Brett, I know, I see your eyes getting big on this one. Okay. So what they're looking for is pain-free ranges of motion. I know this is something that most of you haven't thought about before actually incorporating your practices, but it's a simple way for us to induce flexibility and action into the body without compressive loads. Okay. And the very first times people do this, they are going to be very apprehensive, especially early on if it's really acute, but you're just looking for ranges that can help move them around better that don't involve compressive load. That's what it's all about. But still moving. What they're generally going to want to do is stop moving. And our goal is to try and make them move. Okay. Other red flags would be things like, loss of disc space. But if we're looking at upper motor neuron lesion signs, so if they have a positive Babinski or something like that, or if they have sphincter or incontinence or anything like this, bowel or bladder dysfunction, those would be CIs to any of those movements. And of course, even hanging, most patients like it, but some patients are, no, I can't do it right now. It's too acute. Save it for a little bit later, but you can definitely offer it as a treatment. Minimize flexion with rotation, at least early on, but you are going to want to get the person back there. One of the key things I'll do into rehab about 5 days in is I'll get somebody deadlifting. Okay. And it sounds counterintuitive, but it will be simple, just even with a broom or just a dowel rod, getting them into a deadlift position so they can reincorporate that action into their body movements. And then of course, if you've identified that they have an extension bias, like they feel better with extension, progress into your McKenzie extension protocols. There's nothing crazy about this. Gradually loading into the tissue where you're not having a direct gravity pull down on the spine. Although some people prefer Williams flexion exercises, in which case lay them on their back and bring knees to chest. Yeah, you can see acupuncture and everything else there as well. But the rehab program, pick your McKenzie or Williams. You're going to encourage aerobic activity, hanging from a pull-up bar within the first week. Try 20-minute walks for every 3 hours sitting. Get them moving. For this one mom, this is the one that you would look up right here as you would type in Vizniak mom low back pain. She had to sleep for about a week in child's pose. It was the only position that she could find that decompressed her spine. But then we gradually got her moving a little bit more into cat-cows, into side pelvic movements, pelvic tilts. All of these micro movements are small and easy to do where you can increase load. Even my own disc that I herniated, you can go ahead and I talk about my own treatment protocol that I went through there. And I was probably about 80% better within a week from dropping to my knees, can barely move here, to almost fully functional in about a week. And it was a pretty aggressive treatment protocol, but then I'm pretty in touch with my body and know kind of how far I can push and not push too hard. Key things also, giving emergency instructions. That's got to be there for everybody. Okay. If things get worse, this is what I need you to do. And the prognosis, we'll say it again, the patient feels like they are in the depths of despair when they're looking at this. What are my key phrases? This is common. You're most likely going to recover from this. Lots of people have had this. I've seen this many times before. They want to know that you're an expert and you can help them. They are not by themselves dealing with this. All right. Chances are, and I don't usually say this to a patient, but chances are they are going to have a recurrence. It's just something that occurs for people, right? If the weight gain is an issue, you want to look at the weight loss potentially, but those are your main go-throughs for the disc issue. Okay. Yeah. Yeah, I do this at home. It feels so good. Yeah, just hanging from a bar is going to be a key thing. So those will be a run through on that. And then again, you can also show them other things, right? Show them the straight leg raise test again and take them and move them all the way up and say, hey, remember when your range was right about here and it hurt to do this? Now we can get you up to here and you have this much range at your ankle. So you're showing them small victories, making your assessments therapeutic. Always go back to that. Establish your expertise. And with that movement, you're stretching out the sciatic nerve and its compression over top. Okay. So those are my kind of key instructions. I know most of you are doing a lot of those things, but maybe we can put some extra special sauce onto what we're doing there a little bit. Okay. All right. The next question was, you guys want to do one on a Piriformis syndrome. So that makes me want to share a video with you of Piriformis, okay, of the gluteal region. Yes. All right. So I'm going to go ahead and do that. So we'll fade into Piriformis syndrome, but I'll show you a quick video of this, what it actually looks like and how thick these things really are. And let me find Piriformis syndrome. It's probably going to be, you know what I should do? I should just go old school and pull up the book and say Piriformis syndrome. Where is that? How do you spell Piriformis? 708. I got to click ahead here a little bit. Yeah, the other book, we're still probably a month away from having this, but the ebook version is up on our website right now. Comes with the membership, 708. Ooh, look at all those sweet lines we have to remember. I just did my CE for radiology this morning. Whoa, man. Okay, it was a go looking at some of the MRIs, but anyways, there we go. Piriformis syndrome. Okay, but what I want to show you guys first is the actual video. So that means, where is that video? There you go. Okay, so everybody can see this right here. So this is an unfixed dissection right here. And this is somebody who is 58 years old. The videos I try and show, sometimes we only have geriatric donors, but other times we do have younger donors like this. So this is a 58-year-old. Not overly active, but still pretty active. And you can see how thick the muscle is. You can also see how flexible it is. And that's what a lot of people don't realize is in unfixed dissections, these muscles are really flexible. So I'm going to pause for a second right there. This is a 58-year-old, not overly active. Look at how thick the gluteal muscles are. That's me at 6 feet tall, holding my hand there. And I'm holding at least 2 centimeters to 3 centimeters of muscle right there. Okay. On top of that, what else would there have been? Right? Let's be honest. A little bit of junk in the trunk right back there, right? We all have it. If you're healthy, there's going to be adipose tissue and there's going to be skin. So you're already in, even on a really thin person, you're already in at least 3 to 4 centimeters. For most people, more like 5, 6, 7, 8 centimeters. So there's a lot of tissue that you have to go through to get there before you get to the piriformis. Okay. And then we can go ahead and peel this back. And I'm just trying to show the thickness of it right there, talking about that for a second. Peel that back and you can see the nice red color because the hemoglobin is still intact on these unfixed dissections. And that's the size of the glutes. This is the sciatic nerve coming down right here. See how thick that is? And this is the piriformis. Okay. So just so we're clear on this, the piriformis is almost always similar in size to the sciatic nerve. So again, if you try and tell me that when you're working in there, you're stretching out piriformis, it's going to be just like I showed you with the scalenes and the brachial plexus, you are probably actually compressing on the sciatic nerve, but literally, pun intended, but, okay, that was funny. All right, dad joke right there. You have to go through about 5 to 7 centimeters at least before you get in there. Okay. I don't expect we're having that much effect on it. In real tissue, how many of you have done an unfixed dissection? Everybody's seen fixed, but unfixed dissections, pretty rare. The body is like ice, like super slippery inside. You can't hold on to anything. Everything just slides around. So I don't know that you're able to get a ton of pressure over top of the sciatic nerve. And even beyond that, if you push onto piriformis, what's on the other side of this? You're in the pelvic bowl right here. So if I push straight down, I'm actually going to fade through and push into the pelvic bowl. So you can't actually pin it against a bone. If you look at something like your erector spinae and you push in your middle back, well, I'll stop the screen share here for a second. If you look at something like the erector spinae and you push into your middle back right here, you get to pin those against the transverse processes, against the spinal laminar grooves, so they stop moving. When someone tries to tell me they can pin QL, massage, because I have dual licensure as a massage therapist too. This right here, you're going to go ahead and work into that QL. If you push onto the QL straight in, we'll zoom into this a little bit, you're actually pushing into the abdominal cavity. You're pushing into the kidneys, in fact. And I gave a seminar one time and a therapist was like, thank you so much for, because I show videos on this too. Thank you so much for showing that. Because I had a patient who wanted really deep work into their QLs. I worked harder. The next day he called me and he had blood in his urine. Okay, so that's what you're actually doing. So the same thing, when we go way downtown and look at the piriformis here, if I think I'm pushing into piriformis here, look what's there. I actually slide anterior, and you can see my finger on the anterior side into the pelvic bowl. So you're not actually reaching piriformis directly. This is new information for a lot of people because we've been misled by a lot of our instructors as far as exactly what this really looks like. I'm always about going back to the basic anatomy and then taking it back to what research we know right here. Having said that, it doesn't mean working into this area isn't effective. Okay. You can still work in this area and have great effect. All right. Yeah. So you can still work in this area and have great effect. And then we'll go ahead and look at piriformis itself now on this screen share right here. Okay. So for piriformis syndrome and sciatica, I'm not a big fan of that term. Okay. The problem with sciatica is it's generic. It doesn't really tell me what's going on. Call it what it is. Is it a radiculopathy? Is it a disc herniation? Is it stenosis? Is it really piriformis syndrome, which is fairly rare, that is actually causing this? Well, there's key things that I should be able to do to tell if this is piriformis syndrome or not. So if we zoom in, yeah, this is what the book really looks like. This is way better. It doesn't have those little errors in it. So it's a cluster of neuromuscular disorders, numbness and tingling weakness down the back of the leg, or pseudo-sciatica. I don't even like that term because it just leads to confusion as well. Call it by the anatomical structures of what it is. So it is a compression of the sciatic nerve under the piriformis muscle. This is, again, that same study that shows the variations that we have right there. It's estimated. I had couple of cases that said in between 6 to 10% of cases of sciatica are piriformis syndrome. What can cause it? Piriformis blunt force trauma, the Costanza wallet potentially, sleeping in one position, prolonged sitting. You know that it does have effects if you sit in a long time in one position because your leg falls asleep. So it's legit that you can compress the sciatic nerve. It just takes a lot of load to do that over a long period of time. A couple of key things to get. History, chronic buttock pain may radiate down the leg, worse with walking or squatting, potentially. Patient may have an antalgic gait, externally rotated if it's shorter on that side. The key sign for diagnosis, though, is tenderness and spasm over the gluteal region. We've all had this patient where you sink in and you can feel the one affected side is ultra rigid or ultra sensitive, super tight piriformis. As long as the glutes are relaxed, you can sink in there a little bit. Okay. Lumbar range of motion is going to be normal. They should have no changes in deep tendon reflexes or anything like that because that's going to take you down a different pathway. Differential diagnosis, though, of course, is lumbar radiculopathy, SI joint injury or hamstring strain, facet syndrome, spondylolisthesis. The key thing here is that you have maneuvers where you can tighten it up. This Freiberg's maneuver, all that really is basically this stretch on a ball right here. Okay. You're taking the leg, externally rotating it, flexing up and moving all the way in. All right. What are we going to do? We're going to look at some other tests. Hibbs test, it's okay. One thing that you have to watch with the Hibbs test, there's another variation. It's called a bilateral Hibbs or a V test. Have the person lay down and let their legs be bent and both knees or both feet drop out to the side, and look for a variation from one side to the other where you could see one leg drops down and the other doesn't. That can potentially be a positive finding, but the problem is that doesn't take into consideration femoral, anteversion, and retroversion, right? The bones themselves could be different shapes. So I wouldn't go on that as a specific diagnostic criteria. I'd look for multiple ways to actually figure that out. And then, of course, management. Well, physical modalities are going to offer the best outcomes. Heat and stretching and movement are going to give you your best outcomes. Massage is great. Okay. Massage over top of that area. I'm a big fan of instrument-assisted techniques. You can see the instruments that we developed right there. So that's one of the, I'm saving my hands. Like I do stuff for professional sports teams on occasion. And for the last 3 years, pre-COVID, the Winnipeg Jets have had me out every year to train their staff. And you think you got to work hard on a regular patient. You go through a hockey player who's got ultra thick glutes, you will wear your hands down trying to work into that area, right? Take an instrument out and save your hands. That's what this IASTM is trying to say here. Of course, mobilizations around the hip, SI joint are all going to be a benefit, moving the acetabular-femoral joints, you know, even doing potentially looking at gait biomechanics and even heel lifts and orthotics might be a benefit as well. I'm a kind of a fan too of acupuncture potentially into the area. You might offer some benefit that way as well. And then diet and botanicals, well, it's pretty common stuff all the way through, so I'm not going to go into details there. Simple things patients can do when they're seated. They can go ahead and lift that leg up. Prevention and education. Of course, it's going to be getting up and moving on a regular basis and then giving them a couple, 3 different exercises they can do and follow at home. The empowerment for patients, I've had good success with them rolling over top of a gym ball like this. Okay. And it depends on what the patient can tolerate. It can go ahead and be some people actually prefer a golf ball. Other people are going to prefer, you know, just like something like a tennis ball or racquetball or something like that. But that gets you through the basics there. And if you're asking about differentials, Francis, what you were asking earlier, well, you can flip through these. And that's what I kind of give for each area, right? We give the different differentials and what you would do specifically. And the big win is this. So the research is pretty clear. Patients believe authority. So they believe expertise and authority. Well, you look like an expert in your practice, but you look like more of an expert when you pull out a book and say, oh, look, here it is right here. And these are the exercises you can do. That's why we've changed all the books to have all these different things. For a hamstring strain, what are you doing? You're loading hamstrings, right? I mean, for any injury, for an adductor strain, you're loading adductors. For hip osteoarthritis, you're going to give some distraction techniques, uses of straps and everything like this. But okay, ultimately, my big saying is you have to load a tissue to heal a tissue. You have to load that tissue to heal a tissue. And what that means is if you've had an injury in that area, you need to challenge it respectfully, but you can't stop moving it. If you stop moving it and you stop using it, you're going to see very negative outcomes with it. And that makes me want to get to one specific page in this booklet right here to kind of finish this off for you guys. Motivational interviews are there. Oh my gosh, who wrote this thing? Well, that's actually a good one. So this would be an example right here. This is the case if you look online of the mom who couldn't breastfeed. This is her treatment for a lumbar disc herniation. And literally, we take a picture of her before treatment. You can see the antalgic lean, and you can see her 15 minutes later. She can stand up straighter, and she can actually almost touch her toes. She had to do it very carefully, of course, but she can almost touch her toes again. These are the kind of outcomes that I'll take a picture of a patient and say, look, this is the change that we got with you over this time, right? So I'm looking for a specific graphic right here. Yeah, pain assessment, pathways. This is the graphic right here. Well, it's one of them. Okay, so I'd like to finish off with this one right here, because what happens is fear avoidance behavior. And it doesn't matter what the injury is. We all go into this, and I'll have this discussion with patients on a regular basis. If you're looking at this, screenshot it or draw it out yourself. This is core and foundational for everything that we do. So what happens? Yep, Shannon, get the camera out, take a picture of it, okay? All right. So we have an injury, and there's body damage, and you have pain. That's legit. That's a normal body response. But then we have a choice, and the choice is catastrophization or low fear. Almost everybody chooses catastrophization. So what happens in catastrophization? I have a fear of re-injury and the pain. I am hypervigilant and I avoid activities, and it goes into disuse and depression, and it's a vicious cycle that comes around here. How many of us have patients who define themselves by their condition and get stuck in this cycle, right? I don't want to move it. I don't want to challenge it, or have been recommended by another healthcare provider that, no, you shouldn't move it. You need to relax it. You need your 2 weeks of rest on this, right? This is a patient, and you can hear it when they're saying it. It is if I get better. They cannot visualize future wellness. If I get better. What is our job? Our job is to take people in the opposite direction into this low fear area, return to activity, and see recovery. And it doesn't matter what the condition is. If it's depression, if it's low back pain, if it's a knee injury, it doesn't matter. The sooner you get back to regular activity, the better the outcomes are across the board. And you can tell when a patient is here because now they're using statements of when I get better. When I get better, this is going to happen. And it's our job, cinnamon bun hands out. Okay, it's our job. There it is, Cheryl. You got it all the way up. Cinnamon buns. Make it sweet. Push them into that direction right there. Okay, I love making cinnamon buns. So I make them for myself, for real. I'll cook some cinnamon buns from time to time. And I will also, oh man, this is not even the right place. Yeah, well, that's basically it right there. Okay, and I will also make cinnamon buns for all of my patients. Okay, get them moving, get them loading their tissue a little bit as well. All right, so that basically gets us through 4 hours of content, believe it or not. Did that feel like 4 hours? Probably not. Okay, I hope not. I try and give a fairly lively lecture stream for everybody and focus on key things. So a couple of closing thoughts right here. I just want to go down the list and have people give me a list of key things that they're going to take home from today's session. I don't like doing these conversations or these sessions unless it's actually going to change or influence the way that you practice. So we can go ahead and do those in the comments. And while you're doing that, I'm going to go ahead and give you guys a couple of ways that you can track me down if you want to look at stuff too. You can always find me on Instagram at Nikita Vizniak, or you can find me on Facebook and go and friend me. I just posted an article on MRIs making people feel worse when you just read the interpretation of those. So I'll post all kinds of interesting stuff beyond that. Or you can find me on our website at prohealthsys.com. In fact, I'll do a screen share really quick so everybody can see what's there. If you haven't seen it, it's a lot of schools are now using it as, well, we have a lot of institutional members now where schools actually use this as their kind of standard. So it shows you all of the texts and everything that we offer, but this is the big win for people in practice. If I want to know more about palpation and range of motion, we have videos on all of this content that you can go ahead and look at. Maybe I want to review my muscle testing really quick. We have videos of all of the muscle tests by body region. We can also take you through special tests. So any of the orthopedic tests that I talk about, because it's for schools, I show them all. But when we do more advanced seminars like this for doctors and therapists in practice, then I break it down and say, no, let's make it simple and to the point right here rather than every single test. But like you can click on any of these and then watch a video where I will walk you through the test so you can see, how it's performed, what the interpretation means, ultra simple, quick images like cervical distraction, right? And I'll go through with the common errors that will occur with it and all of that. So all the ortho tests are there, but it doesn't stop there, boys and girls. What if you want to know about specific conditions? All of the conditions are there that you can walk through, and then a whole bunch of rehab exercises that you can see as well. So all that's available on the website. And yeah, we even have this thing called Essential. Even the book that I was teaching you guys from today, among other ones like the updated muscle manual and all of that, all of those are available online for you to look at as well. So instant access to all of that information. And then of course, if you follow me on Instagram, I'm more than happy to answer any questions that you have or anything like that. So, all right. Yeah, so that's a good one. So that's some point of feedback right there. Great. So these are some great ones right here. Movement is medicine. Yes, we know that. Using tests in a therapeutic way. Absolutely. These are my follow-up tests. Excellent neuro review. Good stuff. Yep. Just functional stuff that we need to know. Use exam as therapy and get people moving. 100%. If you guys got nothing else from me, make your assessments therapeutic and go with that minimal effective dose. If you don't think the treatment you're going to offer is going to offer them that much benefit, don't waste your time. Don't waste their time. Get people through a little bit quicker and you can still have good therapeutic outcomes. All right. Cinnamon buns. Yep, totally. That's going to be a winner right there. Cinnamon buns. Okay. Yes, you can. Negative tests are a positive finding. Absolutely. Yep. 3 hours of sitting, 20-minute walks. The research is clear on that. If you wanted the best exercise you could give anybody, get people up and walking and things will be way better for us all. Yeah. If I could give you anything, especially now, because we know that more than 50% of the world is in an urbanized environment. If we could just get people up and moving more, the world would be a much healthier place. I think it's the World Health Organization. Number 4 cause of mortality is lack of physical activity. Like the research is clear on this, and we just have to be part of the puzzle to get people moving better more often. Yeah. All right. Yeah, there you go. Okay, but that's the start. If you can just get somebody to smile and laugh like you just right there, Francis, you already half your treatment was done just with that. That is excellent. Okay.